And Griffin, I missed, and Zager, I missed. Good morning. Yeah, why don't we go ahead, Carrie, and we can get started now that we're at a quorum. We already know that Representative Javner is going to be a little later, potentially. So we'll just go ahead. Good morning. I'm Ned Claxton. This is the Standing Joint Committee on Health and Human Services. We're having an orientation morning, during which we'll be going over some material from the consent decree and the tobacco settlement in the form of the Fund for Healthy Maine. In the afternoon, we'll have a work sessions to go over a number of bills then. I'll start this morning and then have Representative Meyer take over at 1 because I've got to go testify in another committee or hear a work session. So just a reminder to everybody who is joining us to watch, if you are interested in just hearing the audio, you can also go to the YouTube channel. You can find the link on the Maine government, maine.government and legislature.maine.government, and find the link and watch us. Everything we do is recorded, so you can go back and see it later on if you want. For those of you who are just joining us, we ask that you be patient. The technology is new in some ways and also keeps changing on a weekly basis. So we're doing what we can. We're going to slow. It's getting more comfortable, but please bear with us. I think everybody on the committee at this point is on mute, so I think that's a good place to start. We've already talked about being as visible as possible. I'm turning off my phone so you don't have to hear it ring, and that we can't put any content in the chat box. That becomes public domain and shouldn't be used for anything other than the mechanics of the meeting. I think as I see people getting ready to testify, they're correctly identified, but that's important as you get called in. And then when you're done in a typical circumstance, but not this one this morning, you go back to the YouTube channel to watch. Written testimony can be submitted up until the time that we vote. And we're looking for testimony later on. Oh, that's related to public hearing. Ignore that. So we'll stay in the gallery view as much as possible. And let's go around the horseshoe and introduce the committee, starting with Representative Griffin.
Thank you. Good morning. My name is Abigail Griffin, and I represent House District 102, which is Columba and Levant and Cadescade.
Representative Connor is probably busy with his other committee at this point, and Representative Craven hasn't. There she is. Good morning, Representative Craven.
Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Hi, I'm Representative Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
And Representative Zager.
Good morning, Mr. Chair. Good morning, everyone. Sam Zager, honored to represent District 41 in Portland.
Representative Lemelin.
Good morning, Mr. Chair. My name is Michael Lemlin. I represent District 88, which is Chelsea, Jefferson, Whitefield, and half of Nobleboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the 6 coastal towns of Boothbay, Boothbay Harbor, South Port Edgecombe, part of South Bristol, and Westport Island.
Representative Perry.
Good morning. I'm Representative Perry. I represent House District 140, which includes the towns of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Senator Moore.
Good morning, I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan and Hancock County as well.
And Representative Meyer.
Good morning. Thank you, Mr. Chair, and welcome to everyone joining us this morning. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott, and parts of South Berwick and Kittery.
And I'm Ned Claxton. I'm proud to represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. So we'll start off this morning with an orientation, as I said before, to the consent decree. And we're joined here by a number of experts, and we're fortunate to have them with us. So who's to lead off the conversation?
I can if I can unmute my machine.
Welcome, Judge Wathen.
Morning, Senator Claxton and Representative Meyer and members of the committee. I'm Dan Wathen, the court master under the so-called MI consent decree. And I'm pleased to be here and to have an opportunity to fill you in on where we're standing. And I see some familiar faces and I see some new faces, some very familiar faces and some new faces. So I think what I would suggest is I can give you a little update on where we have been recently. And I think Dr. Pollard, who is the director of the Office of Behavioral Health, could tell you what her plans are in terms of meeting the compliance standards. And then Kevin Voivodich is here can discuss the history of it, which is now some 31 years long. And other Phyllis Gardner is here and so on and so forth. But let me start off, and I won't take a lot of your time because I'd like you to listen to Dr. Pollard's plans for achieving compliance. This has been a 31-year effort. I haven't been involved throughout those 31 years. I joined, became court master in 2003, and I've appeared in front of this committee ever since then. And when I first started appearing, I don't think there's anybody here that was on the committee then, but when I first started, Representative Perry, you were, yes. No wonder you look familiar to me. I thought I've only been seeing you for 10 years or so. Well, you'll remember, I don't think it was you, but there were people at the time would ask me, aren't you moving the goalposts on the department? They were really anxious for this to be concluded. And they kept saying, aren't you moving the goalposts? As they make progress, you set the goalposts further out. And I said, no, the goalposts have always been the same. And they were, and they didn't move. What we've done recently, in the old days, the goalpost was made up of 121 performance standards, separate performance standards. And over the years, most of those, many of those were complied with. And so recently we whittled those down to 17 very specific performance standards. Prior to this, in the last 2 or 3 years, we had had an effort we were going to use litigation as a means of enforcing the department's contract. So we wanted to authorize the recipients of mental health services to bring a summary action in court if they were deprived of services that they were justly entitled to under the contract. We've spent 3 years working on that, trying to find common ground with the providers and trying to gather sufficient support for it. And we never really could, not surprisingly, we never really could find the common ground with the providers. They remained opposed to it, and I can understand why. Excuse me, my voice is a little hoarse this morning. So after the last legislative session, when things shut down quickly because of COVID, we withdrew and said, what should we, how should we approach this? Is there a better way? And when I say we, I'm talking about the attorneys for the department representatives, the attorneys for the plaintiffs in this action, disability rights. And we sat together for many, many, many meetings and said, how can we accomplish this? And so what we decided was, look, let's focus strictly on the performance measures that have been troublesome throughout the history, the remaining trouble spots. And let's focus on those. And the department at this time began to exhibit a new willingness and a new capacity to enforce their contracts with providers. And they were doing a much better job. So we said, add a little bit of advocacy, and with the department's willingness to enforce their contracts, let's focus on 17 specific areas. And so those areas are, first of all, what we consider to be the troublesome and the most important mental health services, which are residential treatment at PNMIs, rental assistance under the BRAP program, community integration, which is the most basic form of community mental health service, ACT, or assertive community treatment, which is the most intensive form of mental health service, just one step short of being in the hospital. Med management, which is the most important across the board, and crisis services. The remaining three related to contract management by the department and reporting by the department and the discharge process at Riverview. So we have 17 specific, measurable, understandable performance measures. And we entered into this agreement that we would adopt those, and that when they were achieved for 4 consecutive quarters out of 6, that would constitute compliance with the consent decree, and we would approach the court and ask for the consent decree to be resolved. So that's where we stand, which is really a brand new era. And really it's a question of watching the department's performance and monitoring it over the next 2 years, possibly a little bit longer. And that's where we are. And that's why I think it would be helpful for you folks to hear from Dr. Pollard as to what steps she has taken towards coming into compliance with these new standards. That, I think, is a sufficient introduction for me. And if I can answer any questions, I'd be happy to. But I'll yield to Dr. Pollard.
Before you introduce yourself, Dr. Pollard, I neglected to have the staff introduce themselves, the people who are the glue for the committee. So Erin, if you could go ahead and introduce yourself, if you're still there.
Oh, I'm here. Good morning. My name is Erin Dooling. I am one of the legislative staff for the Health and Human Services Committee with the Office of Policy and Legal Analysis.
And Anna?
Hi, I'm Anna Broom, and I'm the other legislative analyst, and I also work in OPLA.
And Carrie Withy.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
So we'll get to questions for Judge Wathen shortly, but thank you, sir, for your years of commitment to this effort. And now we're going to meet Dr. Pollard.
Good morning. I had the pleasure of presenting to you all a few weeks ago, and I'll try not to repeat too much of the information that I previously presented. I think we could spend hours and hours talking about ways that we are working on reform or improvements in the behavioral health system. But since we don't have hours and hours, I will just focus in on our plans for implementation of the new standards that Judge Wathen described. I have just some slides to keep myself on track. If it's okay to share those. If not, I will do my best to stay focused.
Please go ahead.
All right.
Do you have the screen share option?
I think so. All right, so I won't spend a whole lot of time on the standards themselves, since Judge Wathen described those very succinctly, but I will just reiterate that it's really helped us, I think, to put our focus on the core areas of improving timely access in a variety of different ways, and that there are some other components in terms of agreement of the parties that I'd like to describe in a little bit further detail, since I think those will help us achieve the standards. So I won't read this to you, it's wordy. It's mainly just for those of you who haven't had a chance to review the standards, to give you a little bit of orientation to this. So for the PNMIs, for people who aren't familiar with the private non-medical institute term, there are different appendices. Appendix E is for adults with serious mental illness. And what we've done here is really enact some components both in contract and it's in progress for main care rule to make clear that the department is adhering to its obligations under the consent decree to accept adults with serious mental illness for these services. So sometimes we refer to that by shorthand as no eject reject, meaning that for people who are considered class members or qualifying non-class members, which are really any adults with serious mental illness, the department must provide services for these individuals. And since about 99% of the services provided in the community are done via contract and main care funded providers, that means that we have an obligation to make sure providers accept these referrals. So for PNMIs, that is essentially residential level of care. And it's a really crucial component of the system because without beds available for people who need that level of support, it can hold up timely discharge from the hospital. So one really important area of focus has been on making very clear what are the acceptable reasons why we might agree that a provider could turn down a referral. So that's been an ongoing discussion with providers, as well as the members of the group Judge Wathen described. So unless there's a special circumstance, so it's something such as the person needing a nursing facility level of care, for one example, then we do expect that providers will give us feedback or communicate their decision to us about the referral within 5 days. And that except in cases where we've agreed that it might be appropriate to decline the referral, that person really would be in a PNMI bed within 30 days. So how we've implemented this is the department already has what we call, not a great term actually, but gatekeeper function, where there's a team in my office that works with all of these referrals to place them in an open bed within the PNMI system. So kind of some related work we've done here is to put this in an online system, which will be going live in March. That
Mr.
way,
Chair, I'm not
Yes,
able to hear the presentation. Is this just me or?
I'm sorry, I didn't hear you, Representative Craven. I didn't hear you, Representative Craven.
She stated she's not able to hear the presentation, Senator Claxton.
No, now you're on mute. We're hearing it. I am anyway. Anybody else having trouble? So
Okay, I can hear you now. Thank you.
okay, great. Sorry for the interruption, Dr. Pollard.
that's fine. So we work on every referral to PNMI and make sure we review it for completeness, work with the provider to get the individual placed. And I think the feedback from the state hospitals and Judge Wathen and my team is that that's been going a lot more smoothly over the past year. I think it's helped that we have added a number of PNMI beds over the past year. And also that we have this real clarity on the decision process and that there are circumstances where the department might agree to accommodations if the PNMI deems those requests them and we agree that they're necessary. So we've put in a number of components of the process that I think makes it more efficient, as well as just kind of removed some of the gray area about whether or not a referral can be accepted or rejected. So the department was always obligated to require referrals to be accepted, but we didn't really have clarity on what we've acknowledged as the reality that there are limited circumstances where that may not be appropriate. And so I think we've really tightened that up. And then BRAP, I mentioned to this committee before a little bit of the data around the timely access to BRAP. I think there's been a lot of interest in BRAP recently as we changed our income contribution requirement from 51% to 40%. We've gotten a lot of positive feedback about that making the program more affordable to the individuals who make use of it. And on average, we are issuing those vouchers within a matter of a few days. And the majority of folks are being housed with those vouchers in certainly under a month, in most cases within a few weeks. Oops. So I don't think there's a huge area of improvement needed there for BRAP based on our data there. We have not run a wait list for that program in well over a year for the folks who meet these priority categorizations listed. And then timely access. This has always been in place in main care rule that community integration and assertive community treatment are, the expectation is that these individuals are seen within 7 days of referral. So we've put that into our standards. As I mentioned, it's already in main care rule as an expectation, but we've made some modifications to the process to allow to make clear when somebody is in a hold status. So an individual might say, I understand that this agency is full and I would still like to be seen at this agency rather than the next available opening somewhere else. And that allows the person to be on a hold status until an opening becomes available at their preferred agency. So we've made that operational in some of the Atrezo changes that are going live in March so that it's clear a person is on a wait status. But to say a little bit more about Section 17, the majority right now, the majority of individuals are being seen within 7 days. However, we think there's still some room for improvement there. And the piece that we're putting into place is in main care rule in Section 17 to mirror what we already have in Section 65 and what's really coming in all of the sections of main care for core mental health services, which is that no eject reject provision. So in main care rule, it's called protections for persons with serious mental illness. And it does what the consent decree requires of the department, which is to say the providers have to request authorization from the department, from my office, to decline a referral. And if the provider wishes to end services, they also need to receive authorization. So this only applies to individuals with serious mental illness. But it is already live in Section 65 for medication management and crisis services. The rule, I think, is just now closing for public comment for Section 97, which is the PNMIs, and it will soon follow for Section 17 and 92, which is behavioral health homes. So all of that expectation around acceptance of referral and not discharging somebody against their wishes will be in main care rule as well. And we've operationalized that or put some mechanisms in place in the Atrezo, the Kipro Atrezo system so that providers can request that authorization in that system. And our response will be delivered via that system, which will allow us to track how often these referrals are being declined or refusal is being requested, how often termination against somebody's wishes is being requested, and then what our decisions have been and why. And so we'll have also some tight categories in there where we say what are acceptable conditions. So we're already in the consent decree language able to accommodate if a provider says, I'm full, I don't have any openings, or if I took this person, it would cause me to exceed safe staffing ratio. So that's already an allowance. But what we would ask if the provider requests authorization for that reason is that they assist the client by putting them on a wait list for that service so that other providers are aware of the referral and can help the person gain access elsewhere where there is an opening. I'd say some of the other related pieces to timely access are also the development of the service locator tool that I mentioned last time I presented to this committee, which will have real-time data when we have all the pieces in place so that we can see where the openings are rather than some of the frustration sometimes of calling around trying to find an opening. The full implementation of the Open Beds platform will allow us to see where those openings are and closer to real time. And as I said, Section 65, this is already in place. So some of the ways that we're trying to improve the timely access to service here, we have implemented in the last fiscal year workforce development financial support to the medication management providers who serve people with serious mental illness, and are engaging in a similar financial support mechanism this fiscal year. We are also just in the process of directly funding an additional medication management position in the department through our outpatient services at Riverview Psychiatric Facility. So that will give us an option that we manage directly. If there is a barrier to discharge that's related to medication management, we will have a medication management provider of our own as well. And then we have some standards on readmission. So I mentioned previously that a good metric of how a system is functioning is whether or not somebody is quickly readmitted, whether that's inpatient or whether that's readmission back to the CSU. So that can be reflective both of the quality of the discharge planning as well as the quality and availability of services in the community. So these are two metrics that reflect the quality of community services in part. The crisis services, so we track, and I should say about all of this, part of this is just a quality assurance process. So these are metrics that we already track through the data that we get from KEPRO and a few other sources, such as the quarterly reporting for BRAP. But making sure we're reviewing this on a regular basis, finding our hotspots, so where there are providers who are not meeting these standards, or if the metrics start to slip, can we investigate that further and determine why we might be experiencing a challenge around, for example, timely access, and what can we do to address that? So a big piece of this really is the data tracking and the more timely response on our part if we do see the metrics slipping. So these metrics are already ones that we monitor for the crisis services, and I think I presented a few of those statistics last time about the timely access to services. Some of the things we're doing there are the demonstration of the crisis center in Cumberland County to add one component of what is considered by national best practice standards to be a complete continuum of crisis services. So we have a lot of the pieces in place already in Maine. We have the centralized call system, we have mobile crisis, we have crisis residential, but we haven't had that component of what's sometimes referred to as a receiving center or crisis center that gives the rapid access to in-person triage, as well as up to 23-hour observation or kind of safe holding environment for somebody to resolve a crisis. So not necessarily able to resolve immediately in a face-to-face appointment, but doesn't necessarily need residential level of care, can hang out in what's sometimes referred to as a living room model, staffed by mental health peers to have support and comfort while the crisis resolves, or while you're getting support to move on to the next service that might be appropriate. And also bridging between the crisis and ongoing care if there's going to be a long wait that would not be appropriate for somebody who's experiencing a crisis. So we're implementing that. We're also supporting a few providers who are implementing a model that we're actively exploring currently called Certified Community Behavioral Health Clinics. So we have 2 providers who have grants from SAMHSA and supporting a few other providers to apply for those. And the department is getting consultation on whether or not this full-scale implementation would make sense for Maine. But I bring that up because it is similarly 24/7 availability of services, significant care coordination, walk-in care for a lot of these services, and in-person crisis services are part of that model. So that's another way that we think there will be improvement in timely access beyond what we are already seeing. So management and enforcement, as the judge mentioned, we have historically not necessarily enforced provisions of contract or in some cases rule. So this is really focused on the no eject reject provision. So if we have not granted permission to decline a referral or to terminate services, but the provider still does not see that person for service, or terminates the person from services against their wishes without our authorization, then we have agreed per these standards that we will deliver sanctions in those circumstances. So again, with the Atrezo system, this will allow us to track that. So if authorization is not granted for refusing referral, we should see an admission show up in the system. And if the person has not been authorized to be discharged, we should not see a discharge hit the system. And so we've agreed that we will, that it will be narrow circumstances where we would agree to reject a referral for reasons other than basically not having staffing capacity, and that we will respond when a rule or contract provision related to this has been violated. So sanctions really would be graded or graduated based on the kind of severity of the situation. So if it's simply the provider not understanding the rule and we can clarify that with a discussion and get the person into services, that's sufficient. If it's a more egregious violation, that could result in a plan of correction being required. If it's a very significant violation, it could result in withholding of payment. And so these are all ways that we will be working on enforcement of what our expectations are as a department for timely access and compliance with rule and contract. And so these are standards for just RPC, so state hospital, although we have two, the standards and the consent decree only apply to Riverview. And it's just maintaining licensing, accreditation, certification, as well as timely discharge, which is of course related to all those prior standards around making sure that there are services available in the community and that we get people into them quickly. And the timely reporting of data. So we had put data reporting on hold prior to my arrival at the department and had not been reporting data to the court master and DRM. We are resuming that reporting. We gave them relatively comprehensive data presentation back in December as part of these discussions to give a sense of where we are at baseline, what's our current status for how we function with respect to quality and timely access. And we will do that on a quarterly basis, no later than 60 days after the end of the quarter, to reflect the lag in time for claims data and authorization data that can take a little bit of time to hit the system. But that's all part of our continuous quality improvement as well, to monitor that data and address trouble spots. And substantial compliance, the judge already described. I do just want to say about these standards, hopefully it was apparent in reading them, our goal here was really to make them as objective as possible, as things that were measurable and attainable, because there were some standards in the prior iteration that would be really hard to say for sure, is it met or not? There was some subjectivity. And so we worked very hard here to remove any question or any ambiguity. Is the standard met or not? Should be very clear based on the way that we have created these 17 standards. So I think that removes a lot of question marks. It removes kind of any contention in this, and will be very clear when we either have or have not achieved substantial compliance. So I'll just call your attention to our expanded scope of work for Disability Rights Maine. They previously, or we're currently contracting, although we'll be expanding. We currently contract with DRM on the adult mental health side to provide services, advocacy services in the 2 state hospitals. We will be expanding that to community advocacy as well. And DRM will work with us to make sure that providers and clients are aware of client rights, aware of all these changes, assist when a client So I should mention that in all these standards, there's an expectation that this applies only if a client has met eligibility for the service. So if a client is referred for ACT, for example, but does not meet criteria for ACT clinical criteria, then that would be a circumstance where we wouldn't be kind of counting that toward the 7-day requirement. And to allay any concerns about whether or not these are appropriate eligibility determinations, we do know that it's a very small percentage of the time people are declined for services based on KEPRO data. But nevertheless, for those cases where a client objects and says, you know, I really do think I was eligible for the service, I think I disagree with the decision, clients have a right to an administrative hearing. And so we would support DRM in this new contract in helping a client navigate the administrative hearing process, as well as getting more boots on the ground, so to speak, and having DRM out in the community to help bring to our attention any concerns about rules or contract violations. We will maintain our support for Consumer Council of Maine, who will also help us get the word out about client rights and these changes in expectations. And then in discussion with DRM and others, it can sometimes be frustrating trying to navigate what's the appropriate way to address if there is an access barrier, if somebody has been denied service or is having challenge accessing service. So we've agreed to a single point of contact within the Office of Behavioral Health to help navigate that, to help navigate those situations, rather than being kind of passed from person to person, even though there may be, and certainly will be, other people at the department, either main care services or licensing or Office of Behavioral Health who need to address the issue behind the scenes. The experience of the person requesting the support will be with one individual being the point of contact to help minimize any confusion. And so I've shorthand taken to calling that concierge service. It's not individual level case management, but it is a support person to help navigate what are your rights, and maybe there's a need to simply clarify something with a provider. But we are already have a staff person designated there. And when we have our new website launch, which will hopefully be soon, it will also include the advertisement of that phone number for the single point of contact or concierge. So I think I touched on all these already. And I think I neglected to say that we'll be, while I mentioned we'll expand DRM's contract, I do want to call your attention to the budget initiative that we have for that expansion, to make sure people are aware that that is in our biennial budget proposal. And I think that really covers all the main points of the mechanics, although I'm certainly happy to answer questions and talk further about what efforts the department is engaging in order to make sure that services are available and of high quality, but probably best to let you ask your own questions about that.
Thank you for that. Representative Madigan has a question.
Hi, thank you for being here, Dr. Pollard. I have a couple questions. Do we have any data on what's the wait for folks who have a BRAP voucher and are waiting, to find an apartment, to be discharged to, but they may not be able to find an apartment even though they have that active voucher?
Yes. So we don't really track it as a wait, but we do track the time between the issuance of the voucher to when the voucher is considered housed, or when the person is considered housed. So I'm happy to throw up a couple of slides about that. The issuance of the voucher on average takes place in a few business days. So asking for the voucher to receiving the voucher. And then let me just pull up the data so I don't misspeak on how long on average it takes for the person to become housed. But on average, it is the majority of people are housed in less than 1 month. That, as I understand it from our most recent quarter, that is improving. And there are a couple of reasons why that could be the case. One, we know that during the, this is how bad I am at multitasking. I can't scroll and talk at the same time. The protections during COVID of not evicting somebody, I think, have been helped. So we're seeing less turnover in our BRAP program. People are remaining housed when they are housed, and we are. Sorry, I'm really going to stop trying to talk and scroll because it's just not working. And I do want to give you the correct information here.
You could also provide that to us later on, just as an email, if that'd be easier. Molly's a good conduit.
I know. I'm always reminded that I can just say I'll get back to you later on that. I'm a very stubborn person about it, but I will
While
pay
you're doing that, I'll ask my other question.
Sure, go ahead.
I just wonder, do we have any data on how often clients are being denied admission to a program, upon discharge because of staffing issues, whether that's because of a community-based program or residential services, things like that?
So we don't currently have great data on that. So some programs we do have that information, but the implementation of the KEPRO project that I refer to occasionally is how we'll track that more comprehensively going forward. So currently there's no systematic way that that's tracked as a reason for rejection, but once that goes into effect across main care rules as well as the Office of Behavioral Health contracts, that will require providers to give that response in our tracking system within a Trezzo, so that we'll have that data available.
Thank you.
Sure.
Representative Craven, you had a question?
Yes, thank you, Mr. Chair. Actually, I have a couple.
We have a Brad answer first. Do you want to share that?
Sure. This just gives you a sense of the percentage of people who are, sorry, let me move my view here. So to orient you here, this is the proportion of vouchers that are issued that are housed. And then I'm just gonna click to the next one because I think we have more information on the length of time in that next slide. So length of time to become housed is this graph here. So the majority of people are housed within 1 week to 1 month, some within 1 week, and then you can see it tapers off, which is largely dependent on region. Some of our regions, it's much harder to find affordable housing than others. But overall, the majority of people are housed in less than 1 month.
Thank you for that answer. Representative Craven, you had a question?
Yes, thank you, Mr. Chair. So my first question actually is about BRAP funding. With the uptick in the real estate market in Maine, I wonder whether the funding is better this year, and that you have access to more resources for BRAP. And my second question is whether, I'm having a lot of feedback here. My second question is regarding certified community crisis services. Are they on the ground services, or are they remote services, and where are they located? And then finally, the compliance rule on contract. Last year, as we were looking at the bill to end the consent decree, there was a lot of angst about placing people, requiring providers to serve people when it wasn't appropriate or safe for others in the house, or and the worry about being sanctioned for inappropriate placement. So I just wonder what kind of safeguards you're going to have in place for that issue. Thanks.
I say your questions back mainly to help me remember them. So one is about the level of funding for BRAP that we currently have, and whether that's sufficient given the the rate of housing, I think, if I understood the question.
No, the thing is that the housing market in Maine
Cost
has
of
gone up
housing.
substantially, and I wondered whether our funding has improved because of that and how much that would be.
Okay, and the other questions about CCBHCs and whether those are in-person, mobile versus on-site, and then around basically how are we managing the requirements to accept referrals in a way that respects safety or takes into consideration different level of care needs. So I'm not sure if I'm fully grasping the BRAP question. Are you?
Can I take a shot at it? Can I take a shot at it?
Oh, please do.
I think the question is in view of the fact that the housing market has gotten tighter and prices have gone up both for sales and rentals, have we got an appropriate amount of money available to cover those expenses in the BRAP program?
Yeah, it's a really challenging question to answer. And I say that because there are a lot of moving pieces in BRAP. So the sort of fair market rate varies by region. So this is a statewide program, but the amounts vary by region. We require a % of income contribution as opposed to the amount being completely based on the rent itself. It's more based on the income of the participant. In a lot of cases, those are individuals who have disabilities, so it can be a somewhat predictable amount, although not entirely. But to just give a simplified answer regarding sufficiency of funding, the department had, or the Office of Behavioral Health had, a significant unencumbered balance forward for the BRAP program. So we hadn't previously been expending all of our funds, getting them out into active vouchers. So that balance accumulated. And by our projections, we should be able to meet the needs of the program by making use of the unencumbered balance forward through this biennium. So I guess the very short answer is yes. By our most recent projections, we think that the baseline appropriation combined with the unencumbered balance forward should sufficiently fund the program through the biennium.
About the other question.
Yeah, I almost forgot. There were two more. The second question about certified community behavioral health centers. Currently, there are 2 awards. There's one to Sweetser for the Mid-Coast region, and there's one to Community Health and Counseling Services to the Penobscot County region. Those are, the expectation is that they're a combination of in-person as well as mobile crisis. So the existing mobile crisis providers in both cases will be partnering or part of the CCBHC. So we'll continue to deliver mobile services, but also have in-person services available on more of an open access model for those 2 programs, as well as the one crisis center that we're implementing in the Cumberland County region. We know that a handful of other providers, or at least I'm aware of one solid commitment of a provider to apply for the second round, or in a more recent round, I should say. I think it's more than the second, of SAMHSA funding for CCBHC. And we certainly hope that more providers will get the grants from SAMHSA in order to help them develop and implement the model. There's one more. What was that? That was 2. Oh, let me try to remember it and test my working memory. The third question. Oh, enforcement. So yeah, so we, particularly PNMI, I think was where there was a lot of concern when we were having the discussions in the last session about safety of accepting the referral and whether the department was kind of going to force providers to take clients that they couldn't really accommodate. And so I think we've tightened up the clarity in the PNMI referral process. And by that, I mean, there needs to be equity, and there needs to be a sort of sense of justice and like clarity of the criteria. So what we don't want is a subjective kind of, well, this person seems really difficult, or, I don't think I'm going to be able to manage that person. we want to have really well operationalized criteria so that there is, so that it does become clear what is inclusion exclusion criteria, and that we can not have it be so subjective. Although of course there's some subjectivity inherent in the process, but in other ways we've made it more objective. For example, having nursing facility level of care assessment or traumatic brain injury assessment as part of some of the criteria that are in the referral process that can be sought by the provider if they think the referral isn't appropriate. With respect to dangerousness, there's a couple of ways to think about how we're addressing that. One is, even individuals, so the PNMI level of care is meant to be for people who cannot at that time live independently in the community. So we do expect that for the PNMI level of care, these are going to be individuals who are having some significant challenges. And it would be, I think, unreasonable for us to say anyone who's got any kind of behavioral challenge can't be in a PNMI, because we're not going to keep people in hospitals forever. The PNMI level of support does need to meet the needs of some of these individuals. What I would say is that we are developing a specialty PNMI currently for people who have significant forensic involvement. So that's actively in place, where we're working on what would be the special training needs, what would be the ways that we could more directly support that PNMI for individuals who are of a concern for placement or who would be challenging to place. And then the other thing I would say is, again, the providers can request accommodation and can also request adjustments to what their PNMI model looks like at their individual facility level. So if a provider says, I really need alarms on the doors or something like that, that is a request they can make as part of the referral process. Or if they say, I really need to change my staffing ratio, that's not uncommon. That is something we do pretty routinely. So we have several individuals I can think of recently where the provider said, this person is somebody who I have safety concerns about. I think they need to have one-to-one staffing in addition to the PNMI sort of typical staffing. And we accommodate those requests when appropriate. And I know we've done that several times recently for individuals like that. Sometimes we get consultation coming in for specialty situations where there's a very complex situation, an individual who has very challenging clinical needs, and assist the provider in getting what they need for their staff to be able to manage the situation.
Thank you. We have some other questions. Senator Moore.
Yes, just a couple of very simple ones. Right. Thank you, Dr. Pollard, for the presentation. It's amazing just in the couple of years that I've been around and how much progress that we've made with this. This is just great. I just was curious if we have current data on how many have actually requested the hold for service, or is that a new measurement related to these standards?
Yeah, so the hold for service is in main care rule, but it's not currently operationalized in that unless we sort of went in and did a chart review, we wouldn't see whether or not somebody's on a hold for service. So we are changing that as part of these new Atrezzo parts of Atrezzo so that we can see who's in a hold status. That way it both helps the provider to show like I'm in compliance with rule, because while this person hasn't been seen within 7 days, it's because they're on hold status, but also so that we have a sense of who's sort of hanging out there in need of service, but not actually receiving service.
That'll be great. And then one last question was, will there actually be a dashboard of these standards for everyone's viewing, I guess, to see how we're doing on them, on the standards themselves?
Yeah, I mean, as I understand it, long ago, we posted our reports, I think, to the court master, but certainly we'd be happy to put the data reporting that we are sharing with Judge Wathen and DRM on our website.
Thank you. I think that'd be great. Thanks.
I agree. I love data. I'm happy when people are interested in it.
Representative Stover.
Thank you. And thank you, Dr. Pollard. I really appreciate the metrics. I think that the data is going to show where there are gaps and where there are successes. And I look forward to seeing those reports. I represent a district and a county that is terribly under-resourced. I represent Lincoln, well, part of Lincoln County. And I think from the recent experience with the case at Miles, you'll understand that that's not a random occurrence, that we struggle down here because we are incredibly under-resourced. And when you say med management and community integration, they're wonderful and they're services that we have a little bit of, but not a lot. And we don't have a lot of, there are a lot of other services that simply can't get here. And I live on a peninsula, and they might say, well, we'll come to Route 1, but then you have to leave the peninsula and come out these 11 miles because we're not driving all the way down to you. I'm just wondering if they're, in looking at the picture of resources in the state and looking at these metrics and what the department is looking for, really for compliance standards, if you're looking at possibly additional resources to make sure that there's some sort of way to enhance the resources where in communities and in this case, counties are under-resourced. It's impossible for a provider to meet those metrics because it doesn't exist, if that makes sense.
Yeah, thank you for the question. It reminds me that I forgot to mention the changes that we've experienced via telehealth as well, which I want to acknowledge immediately is not the entirety of the solution, though I think that especially in a state like ours where there just in some parts of the state isn't the population density to support some of the services that you would need to have a kind of enough people to constitute a clinic. Having more implementation of telehealth and availability of that service, I think will be really important going forward. It's always been allowed, well, I shouldn't say always, it has been allowed under main care rule even prior to the pandemic for almost all behavioral health services, but there just had not been the motivation, I think, for people to make that switch. I mean, I can say that myself as somebody who's been a clinical provider for almost 2 decades. I was skeptical as well that I could deliver the same quality of service via telehealth. But when forced to do so, we have seen that for a lot of people, it's made a big difference. And, besides the fact that there are sometimes challenges around transportation and childcare, so that won't change after the pandemic ends. There are a few services that we're looking at, potentially things that we've allowed under emergency. Will we continue those going forward? Because as I said, there were a few areas of service that didn't fully allow telehealth. That said, I think that will do a few things. There's some evidence to show that the availability of telehealth reduces no-shows, which, as I think as people are aware, no-shows are part of what hurts the bottom line of the providers. So part of what can be so challenging about financial viability of mental health services is the sometimes extreme no-show rates. And so, when we're talking about the rates and the funding of the service, that has to be taken into consideration. How much of the time, sometimes 30 to 50 or even higher percentage of appointment times are not being billed for because the person hasn't shown up for the service. So having the immediate availability or the more quick availability that is allowable or that is facilitated by telehealth, I think will reduce that financial burden as well. In terms of where we're supporting, there are lots of ways to answer the question in terms of how to fill in geographic gaps. I also neglected to mention mental health intensive outpatient treatment as a budget initiative that the department has, which I think will do a number of things in terms of savings for more expensive services like inpatient, which will allow us to reinvest differently. So I think, the kind of big picture answer from the department is we're trying to put pieces into place that will avoid more costly services that can be reinvested into the more kind of proactive services. But I don't have, I think, a succinct answer for you on, for all of the services, how we'll address geographic gaps, but we could certainly follow up on a further discussion about that.
I would really appreciate that. I'm very interested in could people mute? I'm getting back to it. I would be really interested in management wait list numbers. I think for all of us, just to look at what is that gap between access and need, and how we could potentially, I really am looking forward to IOP. If there was mental health IOP in this county, I think we could fill the slots very quickly and continue to. So maybe as a follow-up, you could get the numbers on med management wait list, because I just find telehealth is great, but there's still a tremendous gap for us, and I would really appreciate seeing the numbers. Thank you.
Yeah, unfortunately, there isn't a requirement right now for med management wait lists to be kept. So we have information on what providers report if they keep a wait list. Not all of them do, and there's not a centralized wait list for med management, unfortunately. But I think we will have some better data going forward as we record the time as well for med management as we do for other services, from referral to first appointment, and then the ones that we are directly assisting with as the department. We will have some better data there as well, but there's not currently a kind of requirement for med management providers to keep a wait list. The service locator data will give us a better sense of where there's a geographic mismatch when someone needs a service, but there's no openings in their area. So we'll have that data in the not too distant future as well, but unfortunately it doesn't exist currently. But I agree, it's a really important service.
Thank you.
Representative Zager.
Thank you, Mr. Chair. Dr. Pollard, thank you very much. I'm learning a lot today, and this is all very important. My question sort of dovetails with ones from Representatives Madigan and Stover. If the standard is that 75% of people who are discharged have med management within 7 days and 85% within 2 weeks, is there a timeline for getting to 100%? That's number one. And number two, what barriers, you've mentioned a couple, but I just want to get here if there are others. What barriers are there for the good people that are trying to make these programs work for our patients in Maine?
Sure. So I think I know we avoided any kind of standard that was 100% because there are factors where there are things that are outside of the control of the provider and of the department. So I alluded to no-show rates earlier. There are times in which the client doesn't agree to come in within the time frame, or maybe makes an appointment within the time frame but cancels or does not show up for the appointment. So we wouldn't want to expect kind of perfection or 100% compliance due to factors that we can improve upon. But even in really great studies of concerted efforts to reduce no-show rates, no one has been able to get it down to zero. And so I do think we need to take those kinds of factors into consideration. In terms of specific challenges for access, I think one of the things we just have to acknowledge is that we have, as a country, a shortage of psychiatric prescribers, both physicians and nurse practitioners. And that is a very concerning problem, as about 2/3 of the psychiatric physicians are nearing retirement age. And nurse practitioners, psychiatric nurse practitioners, remain among the highest categories for recruitment firms as well. So we're not alone in Maine in having that challenge. I think that there's also, if you talk about more of the frontline staff, there's also the challenge of the fact that we are in an older state and don't necessarily have a huge pool of young people to get into that workforce for, say, the mental health rehabilitation technician positions. But I think we are interested in addressing those in a variety of ways. I mean, I think telehealth will help with the scarce resource of medication management, but also I think that the workforce issue, we have to address that in a lot of ways. How do we attract more people to the field? How do we get people interested in it as a career path? And then I think, as people are aware, Maine Care is, of course, engaging in a comprehensive rate system evaluation to address areas where rates don't align with where the rate methodology does not reflect appropriate salary or wage. So we have a number of ways that we're looking at it. I could probably list a few more, but yeah, I'm trying to remember. You asked about barriers to access on the, were you thinking more the provider side or the client side, or?
Well, I have some ideas, but I'm interested in what your experience. You mentioned shortages of providers and no-show rate. And I think within those, there might be subordinate ones, but that gives me a sense. Thank you very much. That gives me a sense of the chief drivers that you're seeing. Thank you.
Lots of questions. Thank you, Dr. Pollard. Appreciate you taking the time to answer all those. We also were joined by some folks from the Disability Rights of Maine, and we want to hear from them about their perspective on the consent decree and how we're doing with that. So would you care to go ahead and join yourself, introduce yourselves, and then share what your thoughts are?
Sure. So my name's Kevin Voivodich. I'm an attorney with Disability Rights Maine. And my plan today, really, we sent you a packet yesterday that kind of gives an overview of the history and principles, but I was really just going to do a quick run through of the timeline if you'd like, or we can just leave it open to questions. It's up to you, but I can do a quick run through of the timeline and then answer any questions any of you may have, if that's helpful.
I think the timeline was beautifully laid out in the material we got from DRM. I remember shaking my head repeatedly as we sort of walked through decades of the struggles. So most of the people I think on the committee are familiar with some of the steps without being intimately involved 30 years ago, with some of the steps that got us to where we are. And my guess is that that's what we're most concerned about right now is how are we doing and what do we need to do better at, and how are we going to know when we're being successful?
Absolutely. So, I mean, I think just to kind of set the context for us, I think really just the three or four really quick points on the timing, just to help bring you to where we are today from our assessment of things. I think the first, key date is 1995. That's when the consent decree was supposed to be wrapped up and done, originally. And I think I just want to point that. And then you kind of jump forward, and a number of things happen, related to budgets in the state and other things like that. And so compliance doesn't happen. By 2004, the state has tried to go for compliance, and then there's a battle about that. It goes all the way to the law court, and that brings us to kind of a key point in the timeline where that law court decision from the plaintiff's counsel and the consumer perspective really set out what these standards are going to be today, as far as what we're looking at today, as far as the measures and the standards. And the key pieces of that are really that it said, one, it's not an individual right. The consent decree creates no individual right. So these standards are going to be systemic. That's what they are required to be. And two, that the consent decree applies to both class members and non-class members that qualify. So that means that the whole system of individuals, designated with serious mental illness within the system. So from our perspective, looking at things, we looked at, where that decision left us, what was occurring in the system, and talked to the Consumer Council and others to get the actual on the ground perspective from consumers, and tried to think about, what the remaining trouble areas, as Judge Wathen's, most recent report pointed out. And that's where you see the focus on timely access to services, all throughout this, in that, when we get calls at DRM for advocacy, somebody may be being discharged from a service and have nowhere else to go, or really be struggling in the community or stuck in a hospital and not able to get the services. So we really tried to tie, the history of the consent decree and where we were at into where we're at today and what the remaining trouble issues are. So from our perspective, these new standards are kind of, targeted to make sure there's a flow through the system and things kind of keep moving through, for consumers, and we consulted with Consumer Council as well. And one of the things I think that's very important is, as Dr. Pollard talked about, is that kind of concierge or navigator within the department when someone's kind of facing more complicated barriers to service than just, some kind of, mistake or, procedural mistake, something like that, as far as getting people in for intakes. So that's kind of, the overview of where we're at today. And the one other thing I'll note kind of in my timeline in history, which was a critical and key piece, was Riverview, regaining CMS certification, because that is, an improvement on the hospital end, and that, that regulating body oversees them and keeps those, those pieces in line in that respect. And so that was really important for the full package as far as what's going on. So that's kind of just, 5 minutes or less, which is what I thought I might have for the 30 years, but that's what I have for, today. And, we're all here. My colleague, Mark Joyce, is also here from DRM to answer any questions you may have.
So I think my high level question is, are you encouraged by the way things are going? And what's your expectation for having the consent decree retired?
Well, I think, this is these standards are negotiated, long negotiations between us and the department, and they're positive. And it's really designed to get at the issues that, Mark and myself see on a daily basis in cases we do, as far as getting people help. So I think we're hopeful and optimistic that this will target those areas that, us and the Consumer Council hear from folks all the time are really a problem. I can't wait for services, or it's just hard, I shouldn't need a case manager to get a case manager, that kind of stuff. And so we really tried to, think long and hard about, when someone's calling us in crisis and they're saying, I just can't access it, what are the things? And we can do the legal advocacy and the rights, but we also need that kind of partnership with the department to navigate the contractual piece and the enforcement. And I think that's what these standards really are targeted to. And we're hopeful. I think the standards, we want to see them met, obviously, because that'll be a good measure for, that people are getting help within different parts of the system.
Okay, thank you. Is there something that Mark wanted to contribute? He's been patient here all morning.
Oh, no, I can't put my video on, but no, Kevin said it beautifully.
Are there any questions for the folks from Disability Rights in Maine? I don't see any. So thank you very much for being here, and thank you for your short commitment to this project, measured in decades. So thank you for that. I was really, I struck again and reminded that the decree, the breadth of the decree was expanded appreciably by getting to folks who were non-qualified. And I thought that was a huge win for the state and for our mental health community. So that was good to see that reinforced in the material I went over yesterday. So thank you for that. That was a big win for everybody. We're also joined by some folks from the Attorney General's office. And if you want to let in Phyllis Gardner. And I think Ms. Reardon is here about the Fund for Healthy Maine. So let's let in Phyllis Gardner too. Okay. So,
Senator Claxton, Phyllis Gardner is just listening.
Oh, okay.
Today.
All right. So Ms. Reardon, are you here about the Fund for Healthy Maine?
I am. Good morning.
Okay, so we'll take a pause right here while we finish up on the consent decree. I thought maybe the AG's office might have something to say. Are there other comments that Judge Wathen would like to make before you? Oh, I have a question from Senator Baldacci first.
Oh, it was a promotion. I just want to say
the state has an enormous debt of gratitude to Dan Wathen. It's been a while since I've seen the Chief Justice, but I wanted to give him my best wishes. I also want to thank him for his enormous public service over many decades. It's really been a great for the state, and the work that you've done on this consent decree. I concur with our chairman that it's been enormously helpful to people who need help. And but I just wanted to note that you have done so much for the state over so many years, and it's a pleasure to see all the work that you've done here. So thank you, Chief Justice, and it's nice to see you.
Thank you. It's been a labor of love, although bitter at times. But I join with Kevin that I'm very optimistic at this point. I think we're in a better spot than we've ever been. And I look forward to watching the operation of the Office of Behavioral Health, as you folks will. And I hope that my future reports are better and more understandable, probably. So I think we're in a good spot. So thank you very much. And thank you for allowing me to do this all these years, you and your predecessors.
We're in the presence of a legend, folks. So thank you for that.
That means old.
I don't see any other questions. Is there anything else that you wanted to finish up with, Judge Wathen?
No, that's very good.
Okay. Well, in the absence of questions, I think the thing to do is to thank the people who set aside some time to help educate us and help us understand better the history of the consent decree and make all of us feel a bit better about progress and the hope for continued progress. So thank you all for being here and for sharing those perspectives. So before we move on to the Fund for Healthy Maine, I want to note that we've been joined by Representative Javner. And would you go ahead and introduce yourself?
Thank you, Chair Claxton, and I am Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
And Senator Baldacci.
Thank you, Mr. Chair. I'm Joe Baldacci. I'm in the State Senate. I represent District 9, which is the city of Bangor and the town of Herman. Thank you.
Okay, so at this point, we're going to move on to a conversation about the Fund for Healthy Maine and the tobacco decree consent. So who wants to start that process off? I see both Ms. Reardon and Luke Lazur here. I assume they have something to contribute.
I'm happy to give background if Luke then wants to do numbers, or Luke, you can lead if you want.
You can go ahead, Elizabeth. I think the background will be important.
Great. So
welcome and good morning.
So I'm just going to talk a little bit about what the Master Settlement Agreement is, settlements of the Master Settlement Agreement since, and what our office does. So the Master Settlement Agreement was entered in 1998.
And you're from which office?
I'm from the Office of the Attorney General.
Thank you. All right, go ahead.
The Master Settlement Agreement, as I said, was a settlement of litigation initiated by the states to recover healthcare costs resulting from the use of tobacco products by its residents. And it requires the major tobacco manufacturers, which we call the participating manufacturers, to make significant annual payments to the states as long as cigarettes are sold, to abide by advertising and marketing restrictions, and to fund the Truth Initiative, among other requirements. And the states in turn agreed to certain terms as well. Among those, the states agreed to enact a qualifying statute, which we have in Maine, and to then diligently enforce that statute. The qualifying statute itself requires any manufacturers of tobacco products that did not sign into this agreement to pay a certain sum of into escrow accounts in each state that they are selling those cigarettes. So they're basically being taxed as well. The agreement itself has a number of different ways that that amount we get each year changes. And one of those is the NPM adjustment. So if we fail to diligently enforce this qualifying statute, we can have our payment each year adjusted downwards. So the total maximum NPM adjustment is determined based upon an independent auditor's calculation of the national market share lost by the PMs each year. And if a state fails to diligently enforce its qualifying statute, then it can not only lose its portion of that, but any portion by any state that did diligently enforce. So this is important because under this reallocation provision, a state that did not meet one of the two requirements could potentially lose its entire MSA revenue. On the other hand, if all the states were both to meet both requirements, the PMs would receive no NPM adjustment for that year. So this is important, knowing that in 2019, that adjustment for all of the states together was calculated to be $1.2 billion. So that was the maximum that could be lost based on the change in cigarette market share that year. And this has become a hotly disputed matter, whether a state has diligently enforced this qualifying statute. Maine arbitrated that question for the 2003 NPM adjustment from 2010 to 2017. So for nearly 8 years, Maine prepared and arbitrated this question. Maine was found in that year to have diligently enforced its qualifying statute. However, for future years, we decided to settle based on just the cost of that litigation and arbitration. So in 2018, Maine settled the NPM adjustment for years 2004 through 2017, and for 2018 through 2022 based on tax contingency. As a result, Maine received significant back payments for the amounts withheld during those years, so the years of the arbitration. So you may have seen and noticed 2 years, 2018 and 2019, we got much bigger payments. And then Maine agreed to issue credits over a longer period of time, which is why we've gotten slightly smaller payments over the last couple of years and will for another couple of years. So during these transition years now, instead of arbitrating or litigating that adjustment that I was talking about, Maine will receive 75% of the NPM adjustment, potential NPM adjustment amount, and then we'll pay 25% to the PMs. And the reason for this is, as I said, to avoid the costly arbitration and litigation and ensure that we get the payment immediately rather than having it withheld pending a determination of an arbitration. And so as I discussed at the beginning, Maine has continuing obligations under the Master Settlement Agreement. These efforts are led by the Attorney General's office, and in broad strokes, the biggest aspects of the AG's efforts are to uphold to diligently enforce the complementary statute. So to do that, we review application and certify manufacturers for sale in the state, collect and review reports of sales by distributors, monitor the non-participating manufacturer escrow accounts to ensure that the correct amount of escrow is deposited into the accounts each quarter, collaborate with other AG's offices in other jurisdictions, assemble and communicate necessary information for subsequent settlements each year that we go through the process of producing documents to show that Maine has diligently enforced the statute, negotiate with participating manufacturers, and arbitrate and litigate where necessary. So finally, the biggest question is the calculation of that annual payment generally. And there are a lot of variables that go into that determination. There's an independent auditor that goes through the numbers and produces hundreds of pages of spreadsheets each year. And I can't give you the exact number of the payments we will receive this year or next, but I can walk you through a couple of those variables. The biggest one is so that national payment that Maine gets a portion of is based on the amount of cigarettes sold by those manufacturers, the participating manufacturers. And so we're talking only cigarettes and roll your own tobacco, not ends products or other products that didn't exist at the time of the settlement. Those aren't, since it's an agreement, not it can't change. And so ends products didn't exist. And so they are not part of that payment. And then also the inflation is calculated each year, and that affects the amount we get paid. And then our state specific amount is adjusted by that adjustment we discussed and subsequent settlements, so credits and payments. Our rough estimate for 2021, I believe, is in the 41 million-ish range. And I went very fast, and I'm sure there are questions, but let me know what you would like to know.
So are there questions for Ms. Reardon about the AG's handling of this settlement? It looks like you may have answered a bunch of them already.
Or everyone just was so surprised by how quickly I went that they don't have questions, one or the other.
All right, well, let's hear from Luke and see what comes out of questions from that. But thank you for being here to walk us through that. I understand some of the variation in payments better than I did before, so.
Yes, thank you.
Some of the variation.
Okay.
You're up, I think, Luke.
All right, so I am going to share my screen. So I'm going to walk through a few things today. So Elizabeth brought us up to the point of the settlement agreement was agreed upon and funding starts coming to the state. We're going to walk a little bit through the statute itself that was created. We'll also look at a couple of documents that I create, which the goal there is to help you understand how the documents work and what information is provided in those documents. So first, we'll talk a little bit about the statute. So it was created in 1999. It was created after the Master Settlement Agreement, the MSA, was finalized. And the funds that come in have always been identified separately within our system. Originally, they were part of the other special revenue funds that came in. They were specifically broken out within the accounting system, so you could always identify them. But luckily for me, in 2011, there was a piece of law that created a brand new fund, Fund 024, which is the Fund for a Healthy Maine, so that now all revenue and expenditures are identified right in that one fund, which does make my life quite a bit easier. It's important to note that the legislature allocates the FHM funds and the department expends the funds as outlined. So that's always a question that we get. And it's very important to note where the authority to spend comes from. I'll also note while I'm talking about an allocation as opposed to an appropriation, you'll hear about this more as we walk through the budget, but it's just important to note the difference between those two things. When you're appropriating funds, that's really only the general fund. And that is you're actually appropriating money itself to the department to spend. When you're doing an allocation, you're not specifically giving the funding. What you're giving is the authority to spend up to a certain amount of money. That's important because when you are allocating money, there is some form of a revenue source that the department would have to receive the money from. In this case, when you allocate the Fund for Healthy Maine money, you're allocating the funds that are in the Fund for a Healthy Maine. But if you allocate at the level of 3 million, that's the authority to spend is up to that 3 million. Now, allocations can always be changed. If for some reason more revenue comes in, a financial order can be done to change the amount that's allocated to a specific program. But those allocations are more of a one-time change. It still is up to the legislature to, through either a budget or through a bill, to change that allocation ongoing and to make it a permanent change. It's also important to note that any unspent funds at the end of the year lapse back into the Fund for Healthy Maine for future use. So the money doesn't go anywhere else unless the legislature authorizes it to go somewhere else. So the important thing here is if you're wondering, how did we get here? this is the statute for you. So we're going to walk into the statute a little bit. We're not going to talk about the entire statute. We're just going to look at the parts that I think are important for you to know and understand. First, we'll talk about the sources of funds in the Fund for a Healthy Maine. So there are three main sources that the fund can receive. One is the Master Settlement Agreement itself. That's under subchapter 2, that's part A. Then part B is any money from any other source, whether public or private, designated for deposit or credited to the fund. In this case, the funding that the Fund for Healthy Maine receives in this way is the 10% of the Hollywood casino slots revenue that is specifically identified to go to the Fund for a Healthy Maine. And the last bit, part C, is any interest earned on the FHM funds. I'll also note, we're not going to be looking at it today, but in the Revenue Forecasting Committee, when we do the Fund for Healthy Maine, this is the exact three groups that are on the Revenue Forecasting Committee report as well. So next, we'll jump down a little bit to subchapter 3A. And this outlines a couple of important notes for you as the legislature. One, as I said before, any unencumbered balance lapses back to the Fund for Healthy Maine. And you will see these lapsing funds on a document we're going to look at in a little bit, the status document. That's actually outlined right on that document. So you can see how much from year to year lapses. It's also important to note that no FHM funding is available without specific legislative approval. This approval is the allocating of the funds that's done either in the budget or in a bill. And you can see the past allocations in a document we're going to look at in a bit. That's the 10-year allocation document. Subchapter 4 notes some restrictions, and it specifically says that allocations must supplement, not supplant appropriations from the general fund. I always bring this up when I'm talking about Fund for Healthy Maine, because this is a line that's often pointed out during discussions about either the budget or a bill that relate to Fund for Healthy Maine. So that is how it's outlined in statute, but it's always important to note that this does not bind the ability of the legislature to supplant other funding by notwithstanding language in a piece of legislation. And what this really is saying is that essentially previously enacted statutes do not bind future legislatures. They simply provide a roadmap of a previous legislature's intent. I'll also note that though whenever we're discussing this, if you had a bill with FHM and you wanted to do something that was going to supplement, not supplant, someone would probably note to you we should put some notwithstanding language in there. But if you didn't put notwithstanding language, but you did something within the fund that supplemented, that supplanted some funding, it would still be completely legitimate, because notwithstanding language is just a way of clarifying intent. In other words, if you allocate funds, that's enough. That's the legislature saying this is what we're doing, and that is the law. Subsection 5 gets into a general fund limitation, and what this essentially says is FHM funds cannot be transferred to the general fund without legislative approval. And in the last budget, there was a transfer of some Fund for Healthy Maine funding to be used in the Maine Care Stabilization Fund. And if you remember back to our discussion around the supplemental budget, there was a change to some language in the supplemental budget that essentially clarified that that $14.5 million that was sent from Fund for Healthy Maine, all $14.5 million is going to be transferred back. And we'll see that transfer later as well when we start talking about the status documents. So the next part of the statute specifically outlines the health promotion purposes that were created either originally, and there are some here that have been added over time. These were what the allocations were intended to be limited to. But again, similar to what I said above, the current legislature can decide to spend funds in a way that does not meet one of these needs. There are two things you can do. One, you can just do it and either put some notwithstanding language in or not, and it's still the law. Or if you really want to make it clear what you're doing, you could add a purpose to this subsection specifically for whatever you're allocating funding to. The last piece we're going to talk about in statute is this legislative committee review of legislation. This is really important for you in the HHS committee, because any piece of legislation that includes new or increased funding for the Fund for a Healthy Maine and has the support of a majority of the committee must be reviewed by the committee with jurisdiction over health and human services matters, i.e. you. So this means that if a bill is in another committee and they want to allocate FHM funding, if a majority of the committee is on board with that bill, it will come before the HHS committee to review the potential impact on FHM and report back to the committee with jurisdiction over the original bill. It's important to note, though, that that report back is not binding. If you as the HHS committee don't really think that's the way the funding should be spent and you report back to the committee saying that, they can still do whatever they want. They may take it under advisement and change something, or they may just go ahead as it was. But it is a role that the HHS committee plays in anything that has to do with Fund for Healthy Maine. So next, we're going to talk a little bit about the 10-year allocation document. This is a document that we update always for the biennial budget. Whenever there's a supplemental budget, this document gets updated. And what this does is it outlines total allocations for a 10-year span. So the current file, which we'll look at, covers state fiscal year 14 through state fiscal year 23. It's because it includes the current biennial budget in it, which is state fiscal years 22 and 23. This file is broken down by department and then also by programs within the department. It includes legislative position count plus all the allocated portions for costs like personal services, all other, and capital. And it also has a program total, the total that's allocated to that program. And it also notes a year-to-year increase or decrease. So if you're wondering how much FHM funding have we provided to program X in the past, this is a document that answers that question for you. I am not going to walk through the entire document. I could go over this line by line, but I think that would not be worthwhile. But this document can be found either on the OFPR website. I can also send either a link to that or the file to you. But I do want to just show it to you so you can see the layout. You can see here, the very top, it has the Department of the Attorney General. It has the one position. It shows the personal services that are allocated, the all other allocated, and then the total of 136,000 that's allocated. And then in this gray box, it's the total for the department. There is some in Department of Education. There's some in Finance Authority of Maine. And then we get to Department of Health and Human Services, which is the vast majority of the funding. As you can see, it's broken down by different programs, and the names of the programs try and give you some idea of what's in them. But the fact is that the name is not everything. It's more about what's been allocated to those programs over the years that leads to the total allocation you see here. So I'll just quickly scroll to the bottom so you can see that this gray box here is the total for Department of Health and Human Services. You can see that in the current fiscal year, so state fiscal year 21, there are 12 positions, just under 2.1 million of personal services, 60.4 million of all other, for a total allocation in the current state fiscal year of 62,529,614. At the very bottom is a grand total for all departments, which gives you the total that has been allocated over these many years. Next, we'll move on to the status document. This is a document that gives you an idea of how much cash there is in the fund and what the current years look like. So this outlines the available funds in the Fund for Healthy Maine account. It's broken down into three parts. The very top portion is all the revenue, or what are sometimes called resources. The second part is all legislatively approved allocations and other uses as well. And then the final portion at the very bottom of the document in a very beautiful pink box is the total change in ending balance within the Fund for Healthy Maine. The bottom of the page also includes some notes that explain to you what data is included on that status document. So if you're asking, do we have the money to do X? This is the document that balances the checkbook. So we're going to look at two different status documents here, and I wanted to show them both because this one here is for state fiscal years 20 and 21, so the current biennium that we're currently in. And this is important while the supplemental budget's still being worked on. When the supplemental budget is done, this document will be closer to finalized, but this is where it stands right now with the proposed supplemental budget. So the portion we're looking at here is the first part that I was talking about earlier. This is the top of the document, which has all the resources. So first, I'll just note that over here, you can see the years that we're talking about. So this
I don't mean to interrupt, but do you, and I hate to ask, but is there any way to make this screen bigger, or should I be able to do that on my own?
Just one moment, I'll see.
I've been starting to use larger font. I didn't want to have to admit that, but I just did. So.
I'd like to loan you my magnifying glass.
Sorry, I just need that screen a little bit bigger.
Yeah, I'm looking now. I can't find a Zoom.
If you can't, that's fine too. It would have been. It's just easy to read. But no, I'm all set. I'll figure it out. Don't worry.
I made things as big as I could on the screen I was on, because I knew that once it goes into Zoom, it shrinks down a bit. So I'm going to talk through all the bits that are written anyway. The key point here is to help you understand what the document is, because you will receive these documents from me as we move into the budget and start talking about Fund for Healthy Maine. And I wanted to make sure that everyone understood how it was laid out and what its purpose was. So as I said here, this is for the current fiscal year. So state fiscal year 20 is the first column and 21 is the second column. The first group of data at the top are the revenue. This is the revenue that's identified in the Revenue Forecasting Committee, which comes from the sources noted in statute. So the Master Settlement Agreement, the slots, and the interest. You'll see here that this grouping are all the RFCs that have been done during the biennium, because the way the document works is we never change the numbers on their own. So we started with the estimate as of December 2018. That was the base revenue that we started from. And then all we do as we move along through the years is add the changes that the current forecast had on the Fund for Healthy Maine. What you end up with at the bottom are the total revenue in each year. And I'll note that you'll see at the very bottom here, there's a revenue variance item, this 599,000. This is the difference between the forecast and the actual that ended with the final balance for state fiscal year 20 of $49,543, $49,543,354. That number is set in stone now because the fiscal year is closed. That's the only time where all these numbers stay static, because prior to that, there's always little changes along the way. The next group of the resources section is where we get any of the adjustments that are done within the accounting system that impact the fund. So the first group are adjustments to prior year balances. These are just general accounting adjustments that happen every year, only once the fiscal year is closed. And so when the fiscal year closes, I get some information from the Department of Administrative Financial Services that lets me balance this out. So this document matches the actual balance in the Fund for Healthy Maine. The other block that we break out are the lapsed balances. So earlier I mentioned that any lapsed funds, which are you allocate to a certain level, but if not all of those funds are spent, the money goes back into the Fund for Healthy Maine. That's what these lapsed balances are. And you'll note that these two numbers are only in state fiscal year 20. That's because they only happen at the close of the year. So these numbers will not be updated in 21 until the fiscal year closes. So sometime in early July, the final numbers will be known and we'll be able to update this document. Then I'll just notice that at the end here are the total resources for each of the years. So that's the total cash that's available to spend in each of the years. The next part of the document are the allocations and uses. You'll see the first group are transfers, and these are any legislatively approved transfers in or out of the Fund for Healthy Maine. And you can see here that in the governor's proposed supplemental budget, there is that change in Part Q of the supplemental budget that set the $14.5 million coming back to the Fund for Healthy Maine. So that's what this transfer is that you can see. And then the next group are the actual allocations. These are all legislatively approved allocations. So the first line are the baseline from the 2021 biennial budget. So these were the final baselines that were included in the budget. The next line are all the adjustments that were in the biennial budget. So that was all increases and decreases to different accounts that were agreed to in the final biennial budget. The next line are other enacted bills. These are actions that happened in other bills that impacted Fund for Healthy Maine, and it's just summarized here. And then the final row, which is the one in gray, is again, this is what's in the supplemental budget. And you can see that it's a decrease of about 4 million of allocations proposed in the supplemental budget that you have reviewed. So what this all leads to at the bottom is the total allocations and transfers. So it's the total allocation and other uses. You can see that in 20, that number is just over 65 million, and in 21, it's 48.7 million. So the last part we're going to look at is this pink box here, which is where you can see the ending cash balance in each of the years. So what we start with is the beginning balance here of 49.1 million. That was the ending balance in state fiscal year 19 that carries forward into 20. And then the next line is this net change. And what that is the net change is the total allocations for the year minus the revenue. And in this case, you can see that the allocations were greater than the revenue. So you end up with a negative 10.3 million in 20 and a negative 4 million in 21. What that means is our beginning balance of 49 million goes down by 10.3 million to end at 38.7 million in 20. That 38.7 carries over into state fiscal year 21. And then there you have the negative 4 million that drops us down to an ending balance at the end of 21 of 34.7 million. So this, these numbers are important because this is what identifies how much money you can allocate in a given year. So that's why this document becomes very important as we move into the biennial budget. And I'll also just note at the bottom that this is, we specifically note, this is a document that's created by the Office of Fiscal Program Review. We do share it with the Bureau of Budget and make sure that we're all in line because they create this similar information, and we always want to make sure that we have the same information as them. So next, I won't talk as much on this one, but I wanted you to see what it is because this is the same document, but now you'll see that it's for 3 years. So it has state fiscal year 21, which was the second column in the document we just looked at. And then it also has the biennium that is the current biennial budget, state fiscal year 22 and 23. So this will help us walk through the entire biennium to see where we end the year. So you'll note that in the revenue section, which is the first part, there's only one line now, and that's because it's the December 2020 revenue forecast is what you're seeing in that one line. So that gives us the total cash available in each year. And when we move on to the next section of allocations and uses, you'll note that I made a big box around the entire 21 information. This is all the exact same information that was on the previous document, and it ends with the 34.7 million that we saw in that document as well. What you see that's new here in 22 and 23, it has the baselines that are in the 22-23 budget, and then it also has all of the initiatives there in the 22-23 budget for Fund for Healthy Maine. Then you can just see in the pink box that all these numbers carry through just like they did on the previous document, but we end with an ending balance of 5.2 million. So you can see when we started back in the previous year, we started with a balance of 49 million. At the end of this biennium, we're expecting that to be closer to 5.2 million. That's because the current allocations are higher than the revenue that's coming in. This is something that we discussed during the last biennial budget as well. There were a couple of large settlements that occurred that had to do with, I think as Elizabeth was saying, we used to try and settle year by year, but that changed, and there is a new agreement in the way that we settle our the master settlement agreement. And so now our level of funding is lower than what has been allocated, and that's something that's going to come to a head at some point because we can't continue to allocate more than the revenue. But as you can see, at this year, it still ends with 5.2 million in the fund. So the last thing I really wanted to talk about is I just wanted to show you this part of the document. This is shows us in the big red box. These are all the initiatives that are in the budget that are Fund for Healthy Maine. I don't always get to do that in this document. Sometimes I have to summarize and group things. But in this case, there were only 4 initiatives in the entire budget that are Fund for Healthy Maine. So I was able to just put them all at the bottom of the document. So you can see there are 2 initiatives that give $1 million a year. One for the overdose prevention through intensive outreach naloxone and safety program. And the other one to provide a development of strategy of a one-time investment in public health infrastructure to reduce disparities. So those are here. And then there's also a couple of smaller ones, one for the FMAP change and one for Office of Information Technology changes. So this just outlines for you what you saw above. So if you look here at the bottom, these initiatives total to 1.8 million in each year. And if we go back up, the total proposed biennial budget adjustments are the same 1.8 million. So that's what that box does. It just outlines for you the specifics. So that is all I have for Fund for Healthy Maine. So I'll stop there and see if there are any questions.
So does anybody want to put their electronic hand up and ask any questions of either Luke or Ms. Reardon? Are we all feeling shell-shocked by seeing the number or the size of the fund shrinking rapidly in front of our eyes? Representative Craven.
Thank you, Mr. Chair. I have a question about the $1 million for the disparity allocation. So as it was in the budget, I didn't understand exactly how that was going to be spent, whether it was going to be, excuse me, allocated into the community, or is this a one-time payment to set up the structure in the department?
So I can't speak to that. That's a department's initiative. I'm just outlining here that it's in the budget. I think from the description, you can see that it says it's to develop a strategy and it's a one-time investment. So I think the department need to speak to more exactly what their plan is, because I just don't know. And I've only heard what you heard during the public hearing.
Are there other questions that people would like to ask? So as I understand it, the alternatives to keep the balance higher would be to shrink the 54 million allocation on an annual basis that's coming out of the Fund for Healthy Maine now. Is that right?
Yes, that's the only way to really do that, is to decrease how much is allocated.
Right. Okay. Yes, Representative Perry.
Thank you. Is there any discussion in the department, I don't know if you would know this, Luke, about the decreased dependence of the Medicaid program on the Fund for Healthy Maine?
I would have no idea. No, the department has certainly never said anything to me of that sort.
Okay, that's another question for the department. Any others that we want to give to Luke or Ms. Reardon? I don't see anything. So thank you for walking us through that. Will you make that slide deck available so that we can post it on our orientations page for material, and then on our individual computers, we can blow it up if we need to get a closer enlarged visual. I share Senator Baldacci's struggles, but so I don't see any other questions. So as I understand it, that was the extent of our agenda. At this point, I touch base with Aaron and Anna and see if they have anything else that they would like to talk about. And I want to thank Luke and Ms. Reardon for being here to educate us.
If you have time and are so inclined, Luke is also prepared today to explain the monthly main care reports that you've been receiving. And
Sure.
he's able to walk you through that in our remaining time this morning, if you're interested.
Okay, that sounds good. So we can proceed with that if Luke's up for that.
All right, so I'm sharing my screen. I'm sorry, it's a similar. I tried to get things down to the smallest chunk of data I could so that it fits better on the screen. So,
Luke, thank you. Luke, in the interim, I went to view options and then zoom ratio. So
okay, so you're able to zoom on your side.
Yeah,
I wasn't
yeah.
able to zoom my screen. So.
Oh, okay. No, but thank you very much.
All right, so now we're going to talk about the main care documents that I send. Some are sent monthly or as often as I receive them. They're files from the HHS. And there's also some information I wanted to outline that are from some quarterly files that I create that are on the OFPR website, which especially for the expenditures have a lot more detail. So one group of files are the DHHS files. These come with a cover email from me, which I try to summarize the information that's in the documents. And then there's an expenditure document, which is what they call a weekly file, which we get once a month. And then a caseload file that is, in this case, through December of 2020. And then the other files are two files that I create that are on similar information. One is a quarterly expenditures report, which compares through the state fiscal year we're currently in through a certain period of time to the same period of time in the previous year. And it's just trying to outline why we might have increases or decreases. And then there's also a caseload report, which compares the current year to previous months to try and identify why increases or decreases. So we'll start with the DHHS files first. The first piece is just the email for me itself. I didn't used to do this, but now I've started putting a summary of the information that's housed in that email of my own, just to outline some increases or decreases and identify any known contributing factors if there are any. Then there's the files that are actually included with the email. One is an expenditure file, which is a weekly file. The current one that we're going to look at is through week 27, which is through the end of December. The reason it's done on a weekly basis is the main care expenditures are paid via a cycle once a week, or the vast majority of the main care claims are paid that way. And so they do this file after the weekly cycle is done. And this one's through basically half the year. This file has all the main care and related expenditure accounts and funds. This is a really large file. It can be very daunting to just open it up and look at it the first time. I will show you the full file, but don't worry, we're not going to talk about the whole file because there's way too much information on there. We're just going to talk about the piece that you, I think, care about the most. And this file, there are 3 different tabs included in what I receive. The other 2 just include cycle information, so I'm not going to really talk about it here. I don't think it matters too much to you. The main thing is how much is being spent out of the general fund, and that's covered on the first document. The other file we'll look at is the caseload file, which currently is through December of 2020. This includes all the main care members broken into some subcategories, and it shows the month-over-month change. And the file that I send has 2 years on it. It goes back a lot further than that. I have data back to state fiscal year 2012. I just include the most recent 2 years worth on the file when I send it. An important note, these files are presented as they are created by DHHS. So I don't make any changes to these files when I send them. I just simply put them in a PDF and send them. So they are the files directly from DHHS, other than, of course, my summarizing email, which is my own information. So we'll start with that summarizing email. There's a lot here, but I'm just trying to lay out as simply as I can what's gone on since the last time I sent the email. It compares caseload and expenditures to recent history. It identifies contributing factors when known, which can be difficult based on the data that I do have access to. And this summary is based directly on the files from DHHS. There's more detailed information, especially for the expenditures, in the OFPR file that I create. So I'm not going to talk through this entire summary, but I just did want to point out the sort of information it has. We talk about, when we're talking caseload, we talk about the average new members a month. That had been at about 1,200 new members a month, was the most recent average prior to March of last year. Obviously, March of last year, things changed quite a bit, and that monthly increase went up to, we're now at 4,800 members a month. So obviously COVID had an impact, and that's what I was trying to outline here. When we talk about expenditures, similar story. The average weekly cycle through the end of March was 61.4 million. The average weekly cycle since then is up to 65.2 million. So that is a $3.8 million increase, which is a 6.2% increase. That doesn't mean that 3.8 million is all COVID related, because there are other things that happen within the main care account. And I think generally the cycle is going up a little bit every year. And that's largely due to there are certain areas within main care that receive increases every year. And there are certain costs that just go up every year. And so the cycle is going to go up year over year, no matter what. But that increase is quite sizable, and it's definitely due to the COVID pandemic. So the other thing I noted was just that expenditures and membership are both increasing. It's just good to note those things, because when they're not, there's something else going on that has to be identified. In this case, they both seem to be going up for the same reason. So as I said, don't worry about the numbers. Don't look too closely at this. I just wanted you to see the whole file. This is how it comes to you. There are a lot of columns here. It has information all the way back to state fiscal year 17. At the very top, there is this main care accounts general fund. This group of accounts at the very top is really all we're going to talk about. That is the general fund expenditures in the main care and related accounts. Everything below is important information that is related to main care, but it's Fund for Healthy Maine information. It's federal expenditures funds. It's other special revenue for all the taxes and the rebates. And then at the very bottom is main care admin. I don't want to make that all sound like it's unimportant. It is important. But when it comes down to the questions I receive on a day-to-day basis, it's always about the general fund dollars at the very top. So that's what we're going to talk about. So here is just that information. I just want you to see these accounts here are the main care accounts that have a general fund appropriation. You'll note I highlighted in yellow the 0147 payments to providers account, which is sometimes also called the MAP account. That's where the vast majority of the funding in the main care program comes from. So that's why I wanted to highlight it. It's the biggest account, but there are obviously there are many other accounts here. So at the very top, there are a lot of columns, and there's really no simpler way to break down what is here. So I just wanted to walk through what each column is. I'll note that all the green columns are state fiscal year 20, and the brown columns are state fiscal year 21. So the first column in both is an appropriation allocation. And what that is that's the amount that was appropriated by the legislature. The next columns are the allotment. The allotment is the total amount available to spend. So that is what was appropriated plus any other changes that are made to the accounts. Generally, it's from a prior year balance being brought forward. That's the main difference usually with allotments, because when you end a year with unspent funds, main care is not a lapsing account, which means the money stays in that account and can be used in future years. So that's usually the main difference with these allotments. The next column is just expenditures. That's the expenditures, so either to a point in time or for the entire year. For state fiscal year 20, we're through the year. So we ended the year with a total of 840 million of expenditures in these main care accounts. And for the current year, we're through week 27 of 53. There are 53 cycles in state fiscal year 21, so that's how they keep tabs on things in this document. The last column to look at is only in state fiscal year 20, and that's the unexpended balance. This tells you at the end of state fiscal year 20 how much unexpended funds there were. So of the 970 million that was allotted, which is the total of appropriations plus prior year balances, only 840 million was spent. So there was 130.5 million of unexpended funds at the end of state fiscal year 20. We have talked about this a little bit, especially during the supplemental budget discussion. I think largely this occurred because of the FMAP change. The 6.2% increase in FMAP was probably the large driver for why there was so much unspent last year. The final thing I wanted to point out, and this is looked at generally just at the total column. There's a column here that is average allotment. That takes the total allotment for the year. So if we're looking at 21, it's 864 million, and divides it by 53, which are the total weeks in the year, to come up with the average allotment available per week, 16.3 million almost. And then the next column is the average expenditures per week, and that is at 13.3 million. That is the total expenditures divided by the total weeks, which is 27 at this point. And what that gives you is the average variance. And this number is important because this helps us keep tabs on where these accounts are week over week. So as of week 27, so that's through December, the expenditures are under the available allotment by 2.9 million a week. So that's just an important number to keep tabs on, because that number tells you where the unexpended balance might end up by the end of the year. So there are a lot of changes to watch, but that's a good number to keep tabs on.
So Luke,
the
you
next
wanna
file.
Luke, do you want to go back a page and,
Sure.
and make sure I understand that? So that the 2.9 million is really safety. I mean, is really cushion.
Yeah, and that's a weekly number. So what that's saying is, so far through the year, the expenditures have been under the total available funds by 2.9 million a week.
So we could end up with 36 million over the course of a year.
Yeah.
Okay, thank you. Yes, Senator Baldacci.
Thank you. So I just want to, on this chart, basically are you telling us that there was $130 million, and I'm using the word, but surplus? I mean, is that what that 130 million is? That's just carried over to the next budget?
It can be carried over into the next budget. That's exactly what it is it's funds that are left in the main care accounts at the end of the year.
Okay, so I'm assuming that this is an anomaly, having this size surplus?
Yes, very
Okay.
much an anomaly.
What was the surplus the year before?
I off the top of my head, I don't actually remember what it was the year before, but generally when I'm asked about this, it's normal to have 15-20 million at the end of the year, because you are talking about a lot of activity going on in these accounts, and from year to year, it's hard to forecast exactly what the spend is gonna be. So having some left at the end of the year is not a surprise, and but this was. But of course, it's not a surprise when you know that with the 6.2% FMAP increase, if you remember in the supplemental budget, when there were the two FMAP adjustments that were done. One was for the first quarter of the state fiscal year, and one was for the second quarter of the state fiscal year. And they were, one was 74 million and the other was 65 million, I think. So there's a lot of money in that FMAP change, that 6.2% increase. And that had a big part to do with it. Though there also, remember, there was a curtailment order put in place that also impacted state fiscal year 20. So there was a reason for all this money to be there at the end of the year, but it was.
Oh yeah, no, I don't question that, but it's a surplus. So in terms of where it's going to go, you said that it's just goes into the general appropriation. It's an allocation or part of the allotment. Is that correct?
So
of the next fiscal year?
Yes, it can be. I mean, the way it's done is the money is essentially still in state fiscal year 20 till the department does a budget order to move the money from that year to this year. So it's sitting in the main care accounts to be used.
Okay,
and
so I just want to ask this question. So it's not being factored into the current budget that we're being given by the governor's office.
It is to some extent, and because when we start going through the budget and we're looking at some of the language parts, there are 4, I believe, language parts in the budget that take lapse balances within certain accounts and move it back to the general fund. And this MAP account, there's a proposal to lapse $60 million. So that gives you some idea that this 130 million is where the ability to lapse 60 million comes from in the budget.
So that
it's-
means that there's another, I'm just saying that there's another 70 million that's still sitting there. Is that correct?
That is correct, because the money is in the main care accounts as it stands. Yes.
Okay, and what is ultimately likely to happen is that money will be that money will go into the budget at some point, I would assume, even though it's not officially there, because it will be carried into a fiscal year allotment. Isn't that correct?
It can be. That's where this gets, it's because right now the money is still in state fiscal year 20. That's when it was appropriated, and that's where it is until the department moves the money. So that it's not going to necessarily move. And you can see if you look at state fiscal year 21 on this same document, that the appropriated money is actually greater than the allotted money. And that tells me that no money has been moved yet from that state fiscal year 20 into 21. So that's really a question for the department of what their plan is with that money, because that's something that I can tell you, yes, it ended with 130 million and they're going to lapse 60 million of that, but the rest, I don't know what the plan is.
Okay, I don't mean to berate, but it's kind of an important point for me as a legislator, in terms of making sure we know where the money is going and how it's being spent. So when I look at 2021 appropriation, at the bottom it says 954 million, correct?
Correct. Yep.
Okay. And then 20 to 21 allotment 864. So I'm assuming that 90 million, is there 90 million coming out of this? Is that where this 130 is going to go eventually, is to this allotment?
I just can't say that.
Yeah, no, I understand you're not from the department, but
yeah, and I would note that you're right to point that difference out, and that is because of the curtailment order, where within the curtailment order, they're not actually changing the appropriation, but what they did do was reduce their allotment so that they wouldn't spend. When they did the curtailment order, they specifically stopped spending in certain areas, and that's why they decreased the allotment here, was to sort of be in line with the curtailment order, is my assumption, because they wanted to make sure that they didn't spend the money that they curtailed. So that's why that number is down. It's pretty, it's more rare to see the allotment being less than the appropriation. It's usually the other way around.
Right. No, you've done an excellent job laying this out. So the last thing is, Senator Claxton had pointed out 2.9 million. That's the average weekly variance in our favor. I mean, this is all, there's no real good news during a COVID pandemic, but I mean, it's better than being the other way. So basically we're talking about 2.9 million times 26 or 27.
No, actually 2.9 million, it's weekly. So it'd be times 52.
Okay. So we're looking at another surplus of around 150 million. I mean,
assuming that average weekly stays. Now, here's the big point with that. That particular number, that number is that way because of the 6.2% FMAP increase. So where does that stand? What we know now is that 6.2% increase does go through this entire state fiscal year that we're talking about, state fiscal year 21, because the public health emergency was just, now over a month ago. It seems like it was just yesterday, but the Secretary of Health and Human Services extended the public health emergency again in early January, which extended it for another 90 days, which means it's now extended into early April. And why that's important is because this FMAP increase, we get it every quarter through the public health emergency. So if the public health emergency goes through April, that means we get it for the entire quarter that began in April, which is through June. Okay. So we now know that 6.2% increase is going to continue through the end of this state fiscal year. So it makes this discussion that we're having now very much easier, because before we didn't know if the FMAP was going to stick around. Now we know.
Okay. And so basically that is looking at another 150 or 60 million. So we actually benefit from having a continuation of the emergency, if you will. correct?
Yes,
In terms
yes,
of
just
funding
because the
issues?
FMAP continues. Yeah.
Okay, thank you.
Representative Perry.
Thank you. I'm just looking to continue the discussion, actually, looking at this, because it's always been my concern, the FMAP increase has been temporary, and we know that's going to end. And I'm assuming that some of this being held back is so that we are covered for when that FMAP ends. Is that a correct assumption?
I would leave that assumption to the department as to what they're doing with the money, but what I would say is that's probably a good assumption, because that is the concern, right? Is when you know you have an FMAP increase that's giving you this additional money now, it's going to go away at some point, and you're going to have to deal with that. And so I'm sure the department has taken that into account in their thinking.
Does that answer your question, Representative Perry? Great. Okay. Any other questions? I don't see any.
Thank you very much. I love the questions. It makes these documents much more interesting than my red boxes can do. So keep them coming, because there's some more information here that I think might bring up some questions.
I think the red boxes make it possible to have the conversation. Ask the questions.
That was the goal, and you can thank Erin for that, because she created that first one we did on how to read a budget, and these red boxes were in there, and I thought, well, that's a great idea. I'm gonna steal that. So next we'll talk about the caseload file that, again, this is a file I received from the department and send on. So I'll just outline quickly what these columns are so you know what we're looking at. The first two columns are just telling you which state fiscal year we're in and which month. As I said, this file has 2 years worth of data on it. That's all I include in the file I send, just because otherwise it would be way too big. The next column is the traditional Medicaid members. Traditional Medicaid in this sense just means everyone who's not in one of the other columns. So this is just trying to account for everyone who's on main care. The next two columns are the two Children's Health Insurance Program columns. It's a little confusing here because this column says Medicaid expansion. Unfortunately, that term had been used in the past because when the Children's Health Insurance Program was originally created, it was a federal block grant program, and that's our CubCare chip. But then a few years later, they wanted to change the parameters of who could get the program. But when they did that, they didn't put it under the block grant. They did it just as part of the regular Medicaid funding. And so that's the Medicaid expansion group. So the two groups get the exact same services. There's no difference for the member. There's just a difference in the funding source. But they get broken up here so that we have those two different groups. The next three columns are optional membership groups that we've had in the past that we do not have at this point, which is why they're blank. I don't remove the columns because, as I said, this is a file I received from the department and I just send it the way I get it. Those columns are here because obviously if you go back to previous years, there is data in those columns. The next group is the group that includes the Medicare Savings Program and the Dell program. I think this group is Anna's favorite because one of the things she loves most in the world are Quimby, Slimbies, and QIs, which are individuals who are the Medicare Savings Program. Those are individuals who, some of them are fully Medicaid eligible and also receive the Medicare Savings Program, which helps pay for the premiums for Part A, B, and D. Others only receive the payment of the premiums. They receive no other main care services. That's the group we're looking at here. We're looking at the individuals who do not receive full main care, but get some limited benefit. And so that's what this 35,504 members are. The next group is Medicaid expansion. This is the Medicaid expansion that we've been talking about for the last number of years. This is the population that began January 2019 and receives the 90% FMAP. So luckily, this file starts in January of 2019, so you can see from the first month on exactly what the Medicaid expansion increase has looked like. We're currently at 73,864 members in Medicaid expansion. These last three columns just give you the total of all of the previous columns. So the total membership is 345,815. The next column gives you the change from month to month. So we're up from November to December, 5,298 members. and that is a 1.5% increase from the previous month. So next, if there are no questions there, we're going to talk about the files that I create on a quarterly basis. Sorry, I'm a little behind. This is only through the first quarter of state fiscal year 21. The supplemental budget and the biennial budget have taken up all my time since January came, so I haven't been able to create these files. But I will, as soon as I possibly can, be creating files that go through the second quarter as well. But I wanted to walk through these so you know what the files are and what they do, because I like to think they provide some very good information, especially since I create them. So the first one is similar to the first file we just looked at. It's an expenditures file. As I said, this is through the first quarter of 21. This provides a written overview of the first quarter, comparing the previous state fiscal year to the current state fiscal year. In this case, it's comparing just the first quarter of each of those time periods. It outlines increases and decreases, and I try to provide explanations to everything that needs an explanation. It also tracks expenditures compared to the allotted funds. So I try, as I'm on that file, to just basically what I'm trying to say is we're going to be okay or we're not, because there are some years where what's allotted is less than what's needed. And so I always try in this document to at least outline that very quickly so everyone knows where we are. It also includes a table with all the expenditures by expenditure categories, and I'll talk about that a little more when we see the table. And it also includes additional tables and charts and appendices as I see as needed. Really, it's based on what information I need to provide that quarter, and that changes all the time, really. The other file we'll look at is a caseload file. Unfortunately, I don't have any additional data when it comes to caseloads, so it's the same information that is provided on a monthly basis, but I break it down a little more. I have some additional charts and tables just to break the data up a little more. And I, again, outline increases and decreases and provide explanations when I need to. So these files are created by OFPR. We use the accounting system data for the expenditures, which means I do have more information than just using the weekly file that I just showed you, and then using the DHHS file for caseload. The important thing to note about the accounting system is I do not have all the information I need to answer every question. It's just not available in the accounting system. It only has the data at a certain level of detail. The claims detail is where sometimes you need to go to get those answers, and that's only housed with the department. So this is the write-up that I had through the first quarter of state fiscal year 21. I highlighted the important notes that I made. So the important thing to note is expenditures are up 107 million. At first blush, that would seem like a large amount to be up in one quarter from year to year. But in this case, it was pretty easy to explain. There were really two causes. One was Medicaid expansion expenditures were up 60 million. So in the first quarter of comparing the first quarter of last year to the first quarter of this year, we spent 60 million more in Medicaid expansion. And that's an increase we expected because we knew membership was still climbing. The other increase is really due to rate increases and program changes. Some of those were done in the biennial budget, some were in separate bills, but there were a number of increases to programs within DHHS that started last year, but they weren't fully ramped up until this year. And so the difference between those programs is about 47 million. So that right there is the 107 million increase that we had. So with that, I felt comfortable that there was nothing more that needed to be explained with the increase because it was expected. Now, on the flip side, when we look at general fund, because I always break down the general fund separately, general fund expenditures are down 74.7 million. So normally in a normal year, if total expenditures are up 107 million, you'd expect general fund expenditures to be up as well. But in this case, they're down, and by quite a large amount. But again, it was fairly easy to explain. In state fiscal year 20, there were a number of transfers in the first quarter that were for the Riverview Psychiatric Center disallowances. That increased expenditures last year by 58.5 million. That was a one-time item that we knew about and expected, but that meant that 58.5 million that was spent last year was not going to be spent this year. So that was a decrease we were expecting. Secondarily, there's this temporary FMAP rate increase that we've been talking about quite a bit. And that increase immediately decreases how much general fund is spent on each individual claim. And so that's the other portion of the decrease. So are there any questions on that explanation?
I don't see any hands.
Not seeing anything. So I'll move on. This is the expenditure detail. I'm not going to get into the full chart, but I just wanted you to see it. You'll note on the far left, it says expenditure categories. And you can see there are 22 categories that all the expenditures that go through the system are categorized to. I tried to make these categories as close as I possibly could to the way that the department forecasts the main care expenditures. In some cases, I can't do it because they do have claim system data, and sometimes that's how they identify certain things. And there's other ways that I just don't have access to. So I did it as close as I possibly could to the way the department does it. So at least it's some comparison, hopefully for them if they see this information. And in all this chart, you'll note, I note all the increases in blue and all the big decreases in pink. There are a lot of blues. That's not surprising because total expenditures were up 107 million. So we expect that. And it was up in these categories specifically for reasons that made sense as well. So I didn't really get into any more detail on that. But there was this one that was up 594 million and 594%. And that immediately would raise some eyebrows. So I wanted to explain that. You'll see here that this line, the other professionals, was 1.6 million in 2020, and it went up to 11.5 million in 21. That's an increase of 9.9 million. 9.2 million of that increase was due to a one-time charge-off journal entry that was done. That's a normal accounting function that happens from time to time. Some charge-offs were identified during an audit, and they did the journal entry. So that increase was the entirety, basically, of the increase in this line. So there was nothing, though that number looks shocking, in the end, it's totally expected.
Luke?
Yes.
Just for reference, on my screen anyway, I see some faint yellow, but no pink or blue or anything.
Okay, so maybe those don't quite show up the right way on Zoom, but the are those the percentages where you see a faint yellow?
Oh, yes, I see
Yeah, they're on
those,
the
and I
percentages.
appreciate it. I just wanted to let you know for
Okay.
future reference.
In the document you receive from me, they will be pink and blue, so it might be a little easier to.
I'll look forward to that.
I'm seeing the pink and blue.
Well, I did qualify it. It said on my computer, so it may be that
Yeah.
since I'm not Microsoft.
So the other document that I create is a caseload document. This has a little less detail simply because I have less detail to break the data down. But the important things to note here are, one, these headers that you see here are the same as the headers that are on the file that you receive monthly. I do remove the 3 columns that are empty at this point because there's no point in having them on my document. But it basically outlines the same data. So what's important here is that caseload was decreasing prior to Medicaid expansion starting in January of 2019. And then from January 2019 through March, it was increasing. At that point, it was about 1,200 members a month, I believe, through that period of time. And then from March through now, we're at a point where that increase is quite a bit more. And over the first quarter of state fiscal year 21, the caseload increased by 11,627 persons, which is about an average of 3,800 persons a month. I'll note that the data that we looked at prior went through December, and that increases up even more in the last quarter. So that's something we're gonna have to keep an eye on. So the last file that we're gonna look at it's the same information as we have here in the summary document, but it's just broken down a little more. It's broken into the under 21 group and over 21 group. And then within those groups, these are the membership categories within main care that the person qualified under. I'm not gonna go through them all, but I just wanted you to see that that's what this data is providing. And in this case, this table that I include with the document has the last 6 months broken out this same way. I will note that the total of this is 332,000. And if we go back to the previous file, the total was 331,000. The difference is simply this family planning group. The department doesn't include the family planning group in their regular main care caseload file. They sort of break it out. I just include it because I think the group, they're receiving some main care services. So I put them in for the sake of that, but that's why there is a difference. And just for some background on what that group is, that group is individuals who are eligible for family planning services only, up to an FPL of 209,000, where the regular Medicaid FPL is 138,000. So that's what that group is. I include them because I think it's important to note that they're there, and how many there are, but that's why there is a difference. So with that, if there are questions, I would say you can ask me now. You can email me anytime. You can call me anytime. The only thing I ask is please don't ask me to Zoom. I've done enough. You've done enough. We've all done enough. I'll talk on the phone. So are there any questions?
We'll try and respect that. Do you want to unshare your screen so I can go back to Hollywood Squares and keep track of committee? Thank you. All right. So are there any questions of Luke and his exposition? I think you've answered all the questions we plan to ask for the rest of the biennium. So
yeah, good luck.
Good luck with that until this afternoon, until Wednesday.
Yeah.
All right. Any questions, anybody? All right. Well, thank you, Luke. That's always very helpful to have you do that. And I'm glad you're there to do the translation work for us.
Well, thank you for the question today. That's always makes this a lot more helpful, I think.
So now we're back to the glue, and I'm going to check in with Aaron and Anna and see if there's anything they have to do before we entertain a motion to lunch. No
Not
pressure.
on my end. I
No
don't know.
pressure. Okay. And how about you, Carrie? Are we all set? All right. So it's the same link for the afternoon. As you step away, please mute and stop your video. I'll entertain a motion to adjourn for lunch and reconvene at 1 o'clock for the committee.
So moved.
And all those in favor? I heard a second. I saw hands. All right. Thanks, everybody. See you at 1.
like we're waiting on Senator Moore. So we are waiting on a senator. 3, 5, 6, 7. There she is. It looks like we're all set. So we'll get started. Good afternoon and welcome to the afternoon portion of the February 23rd meeting of the Joint Standing Committee for Health and Human Services. On our agenda today are a number of work sessions. We are gathered here live behind our virtual horseshoe, and we are broadcasting as well on the Maine Legislature's YouTube channel. And you can watch our proceedings there as well if you subscribe to the Health and Human Services Committee channel within. Several of our members are off presenting their bills and participating in work sessions in other committees, and will join us as we move through our schedule this afternoon. So we will begin our work session with LD 24, an act regarding certificates of birth, marriage, and death. Our analyst, Erin Dooling, will lead us off with a bill analysis. And so I will open the work session on LD 24.
Okay, good afternoon. So the bill analysis has already been posted to the committee materials page. It might be easier to, I mean, it's up to you, it's your call to have you pull it up there, or I can screen share it, whatever your preference is.
Why don't you screen share it with us?
Are you seeing the committee materials page at this point?
We are.
Okay. Okay, so this bill is a department bill that amends the laws regulating the certificates of birth, marriage, and death, and it accomplishes that in a number of ways. And the way I've summarized the bill here is by section, just to walk through what each section does, because each of them does a slightly different thing. So the first section is a technical amendment. It's not any kind of substantive change. It's correcting a conflict when two pieces of legislation last session.
Oh, I was looking for that.
I think Anna is not muted. Two pieces of legislation amended the same section of law creates a conflict. And so section 1 simply puts the changes from both of those pieces of legislation in and fixes it. Section 2 requires that the parties intending marriage must sign the marriage license when it is issued or when they are married. Section 3 requires deaths and marriages occurring in an unincorporated place to be reported to a municipal clerk or registered in the electronic registration system. Current law requires that process for births occurring in an unincorporated place. The department testified at the public hearing about really a technical change that's reflected on the bill analysis here. I think the electronic birth registration system was a holdover from when the statute just covered births in the electronic system. So it's just fixing it to refer more broadly or generically to an electronic registration system. And sections 4 and 5 work together to authorize the department to amend a birth certificate of a person 18 years or older born in Maine by replacing the name of a biological parent when there is a when there is DNA testing to prove evidence of genetic parentage. In terms of fiscal impact, the preliminary fiscal impact showed that a fiscal note was not required as drafted. If you were to make any kind of substantive changes, we'd have to send it back for that fiscal note review, just to be sure. And the committee had questions during the public hearing, but I believe they were answered by the people presenting during the public hearing. And I believe that there's a representative from the Division of Vital Records available in the attendee list if the committee has questions.
Okay, thank you, Erin. Questions from the committee? Just use your raise hand function, please, if you do. Actually, I see Representative Javner and Representative Craven. Go ahead, Representative Javner.
Thank you very much, Madam Chair. It takes me sometimes forever to find my raised hand. So I have a question that for section 4 and 5, if the person from the Vital Records Department could just give me a real life scenario of what that even looks like or what that means for the DNA testing.
Okay, yeah, I think for Carrie, her name is Kim Hagen.
Okay, thank you.
I'm not seeing, oh, there she is. I'm sorry. There's Ms. Hagen.
I'm sorry, it was spooling. I was getting a, okay.
No problem.
Sorry.
We know there's a little bit of dead time there.
It was just spinning around. I couldn't go anywhere. Good afternoon. Yeah, I'm Kim Hagen. I'm the Director of Data Research and Vital Statistics and the State Registrar. And we have had cases where when first of all, these are all 18 and older records. So there are no children that where paternity would come into play. But we've had cases of adults where there has been another father listed on the birth certificate. And the mother might have even said, I don't believe he's your father, but he signed the record as the father at the time. When DNA testing is done, they have found that he is not the father. And we have had no ability to remove that father from the record to put the biological father on. So this language would allow us not only to add one if there was not one there, but to replace one if there was one on the record.
And sorry, I just have one other quick question then.
Mm-hmm.
Is this totally by the request of obviously the person that's 18 or older? They're the one requesting the change. It's not the person's that DNA has been tested and they are found to not be the biological parent. Can that parent request that it be changed?
No, not administratively. It would be a court order for that.
Okay.
But it would have to be, it could be anyone listed on the record. So the registrant or either parent that's listed.
So the person that's listed can request it if they're not the correct person.
Correct.
Okay. Thank you very much.
Representative Craven.
Thank you, Madam Chair. I really didn't have a question. I was going to make a motion, but maybe we're not ready.
Do I have any additional discussion or questions from the committee? Seeing none, then Representative Craven, I would entertain a motion.
I would move ought to pass as amended.
I'll second that.
We have a motion and a second.
What's the amendment?
What's the amendment? Yeah. What is the amendment?
Representative Craven,
Yes.
it's an ought to pass.
Didn't the department put an amendment on the bill, or?
They suggested one. I didn't want to assume that that was your intent, because we have to speak what the substance of the amendment is.
Okay, then I'll just move the bill, move LD 24.
Okay, an ought to pass. You're moving an ought to pass. And
okay.
And do we have a second?
A second.
Okay. Carrie, I think we're ready to take a vote.
Time out.
Go ahead, Senator Moore.
I'm just wondering if we should not consider the department's proposed amendment, because we would need to, instead of calling it an electronic birth registration system, it would just basically be an electronic registration system. So maybe we should consider that amendment, because that really is not properly labeling the system. So Margaret, you were correct, Representative Craven, you were correct in bringing that up, but we just didn't have it into the words.
You're on mute, Margaret.
I will once again withdraw my motion and wait to have the amendment added, because I think I was probably not there, but I just thought it was already amended.
Can we just get clarification on exactly what that amendment is, please?
Yes, it's in section 3 of the bill, and it corrects the term electronic birth registration system to electronic registration system, because now that section is including marriage and death, not just birth. So that was what the department proposed, but it's not changed yet. It would have to be incorporated as an ought to pass as amended if that's what the committee wanted to do.
So circling right on back when Representative Craven had it right from the start, I would entertain a motion.
Okay, so I would move LD 24 ought to pass as amended.
And I second that.
Thank you very much. Carrie?
Representative Zager. Representative Zager is absent. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Representative Perry.
Yes.
Representative Perry, yes. Senator Baldacci. Senator Baldacci is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Davner.
Yes.
Representative Davner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton. Senator Claxton is absent. Representative Zager.
Good afternoon. I apologize for joining late, bounced between committees. Which bill are you voting on, or did you call in to vote for?
We're on LD 24. This is an act regarding certificates of birth, marriage, and death. It's a department bill.
Yes, I remember it. My vote is yes. Thank you.
Representative Zager, yes.
Thank you.
That's yes, 10. 3 absent.
Thank you, Carrie. Do we need just a minute or so for you to alert the sponsor of LD 47 that we're ready to move into his work session?
Representative Brennan is actually here.
Excellent.
Thank you.
Thank you. So I would open the work session on LD 47, an act to fund the state's free health clinics. Turn it over to Erin for her analysis.
Okay, and I'll just share my screen quickly. There's not a ton on here, but so this bill is an appropriation of one-time funding for the state's free health clinics in Maine. The appropriations total $500,000 over the 2 years of the biennium. This bill would require a fiscal note. In terms of information the committee requested, I think most of those questions were answered during the public hearing, but I did want to make note of a discussion that occurred regarding how money would be apportioned between the 6 clinics. And so I just wanted to note that an RFP is not required under this bill as it's currently drafted. It would be up to the department to apportion that money, and they would just be able to decide. If the committee decided to wanted to direct that decision-making process, you have the discretion and authority to do so. You could, for example, identify criteria that you might want the department to consider in apportioning the money. You could direct the department to meet with like a stakeholder group of clinic representatives in terms of deciding how to apportion the money, or the committee could decide how much would go to which clinic. So you are not limited in that way if you wanted to provide more direction to the department. Otherwise, it would be up to their discretion if it was a straight appropriation like this.
Questions, discussion from the committee? Representative Perry and then Representative Craven.
Thank you. I guess my question is, we're talking that this money is coming from where?
Sorry, the general fund.
Okay, thank you. I thought I had heard Fund for Healthy Maine. That's why I was asking on that.
Yeah, no, it's general fund, Representative.
Representative Craven. You're muted, Margaret.
Thank you, Madam Chair. I would like to make a suggestion that the department allocate the funding through grants, and that organizations that the free clinics should apply for the grant as they would qualify, or as their population, the population served would qualify them for getting the dollars.
So a grant application process. Comments from the committee? Did you have a follow-up question, Representative Craven? Your hand is still up.
No, but maybe I would like to hear from the sponsor about how it should be allocated.
Okay, Representative Brennan. Carrie, could you bring him in? There he is. Welcome, Representative Brennan. You're muted, Representative. Representative, you're muted.
Yeah. No, I got my video and I forgot to unmute at the same time. So thank you. I appreciate it. And I appreciate the question from Representative Craven. I'm sorry I wasn't more explicit in the bill. It's fairly normal for the department when they get an allocation of this sort that they establish an RFP process for granting the money. Obviously, every clinic in the state is not uniform, and the intent was never to have an apportionment that would just be dividing 250 by 6. It would be dependent upon how many clients were served, what the budget might be, demographic data, geographical data the department would use to then allocate the money. And again, it's fairly standard. They do it on a regular basis where they're given an appropriation and then they establish a request for proposal process with certain criteria and then apportion the money appropriately. So I agree with you, Representative Craven. It should be grants. It's intended to be a grant. And I would, again, if this committee were to direct the department to develop the criteria to go through a request for proposal process, I think that's the fairest and most equitable way of distributing the money.
Thank you, Representative. Further comments from the committee? Seeing none? Yes, Senator Moore?
Madam Chair.
Oh, I'm sorry about that. I didn't see you. Your hand, as you've been told several times, your hand is right over that light. Oh, I'm sorry. Go ahead, Representative Connor.
Thank you, Madam Chair. Representative Brennan, would you be opposed to a dead equal split of all funds through the 6 different clinics?
Well, I wouldn't pose it that way. I wouldn't say opposed. I would say I don't think that's a good idea because, again, each of the clinics in terms of their size, who they serve is very different. Obviously, the Portland clinic is much larger, covers a larger geographical area than probably the clinic in Knox County. So it was never my intent to divide 6 into 250,000. My intent, again, was to allow the department to establish criteria, and then based on that criteria, they would make a decision in terms of how the money were allocated. It may well be, I don't know, for example, the size of the budget in Lewiston. A grant to them of $10,000 to $20,000 may make a huge difference. I also know a grant to the city of Portland of $50,000, we'd be able to serve an additional 100 people. So I think those are questions that should be answered in the RFP process, and recognizing that the 6 clinics are different geographically and the populations they serve and the capacity they have in terms of serving people.
Thank you. That is all I had, Madam Chair.
Thank you. Representative Javner.
Thank you, Representative Meyer. I appreciate that. We saw this bill last year as well, or the last session, excuse me. And we all appreciate the work that is happening there. Again, it's from, my perspective, it's a nonprofit, and my position hasn't changed, that I think that these fundings, especially in this time, need to be looked for elsewhere. So I will not be supporting this bill today. Thank you.
And Representative Stover.
I just had a clarifying question for our analysts. Aaron, where it is a new and expanded use, it would require an RFP regardless, correct? Versus sole source, which you really, unless there were existing contracts, it would need to be grant or competitively bid.
I don't know. The department can answer that question. My only point was that the legislation itself doesn't direct an RFP, just like other legislation, like the House bill that got passed specifically included protocols with dates and criteria for an RFP.
Thank you.
Representative Craven.
Thank you, Madam Chair. So it's my understanding that RFPs, are very cumbersome and cost a lot of money, and we're only having $500,000 here. So that's why I thought of a grant process, such as the way that they gave out dollars from the CARES Act, which took a lot less time and was much less cumbersome than creating an entire RFP. So I just wanted to say that.
Thank you. Representative Brennan, comment on that?
Yeah, I agree with Representative Craven. I mean, I would want to get the money out as quickly as we possibly can and with the least amount of paperwork and with the least amount of burden to the local clinics. At the same time, I think there needs to be some accountability. There needs to be some criteria established in terms of how the grants are given, and that there's also the people receiving the grants, the organizations, that there's opportunity for them to report back and to make sure that we understand what they've done with the money. So whatever the analyst or this committee decides is the most prudent and quickest and most efficient way to get the money out, I'm more than happy to go in that direction.
Thank you. Do we need some input from the department on how best to approach this? Is Molly here with us? Hello, Molly. Ms. Bogart.
Hello. Good afternoon. If you want me just to respond to that specific question. So Molly Bogart, Director of Government Relations for the department. For everyone, I would echo the concerns about RFPs being cumbersome on the department. That said, Representative Stover has much more experience than I do doing this type of funding within the department when she worked with us. And so I would have to get confirmation from our finance folks about whether an RFP would be required, but allowing us the leniency in the bill not to have an RFP, if that is allowed otherwise, would certainly be something that we would welcome. And, any clarity that you can provide around your intent for distribution is also welcome.
Thank you. Representative Stover, did you have a comment?
I just wanted to respond to Molly. Molly, I actually think the department could, I like the word could, do a sole source justification based on the amount of money and the number of providers. You have a limited amount of funds and a limited number of providers. And so you could explore that. And that would allow you that time savings, if you would.
Thank you. So we've got, it sounds like the committee is moving towards away from the RFP process, and it sounds like there is some mechanism for establishing criteria in a grant type of a situation. Erin, do you have enough information here to?
I think so. In terms of, I'd have to look for the specific language in terms of actually directing a grant process. But what I'm unclear about is whether the committee is setting any of that criteria as part of this legislation or not. I don't have information for that.
Thoughts on the committee setting the criteria, or do we leave it rather loose based on the volume that the clinics are doing and the number of people they're serving? And go ahead, Mark. Representative Craven.
Thank you, Madam Chair. Well, I think that we have some models, like I said before, because most of the CARES dollars were given out to help to, organizations through grant writing. Maybe I'm using the wrong word, but applying for the dollars,
Yep.
and that the department would set the criteria. And it would be my wish to include the population that's served. How many people are served in that clinic at any given year or 6 months or however that's going to be counted, because I think that's the fair way to distribute the dollars. Thank you.
Additional thoughts, questions? Representative Brennan?
Yes, thank you, Madam Chair. I would just say I'd be fine if the committee were to give the discretion to the department to establish criteria and to provide grants accordingly, and that there then be a report back to Health and Human Services Committee and/or the department on who was awarded money, how much, and what they did with the money.
Yeah, I would agree. I think that's that makes the most sense, is to give that discretion to the department. And as Representative Brennan just described, with a report back to us on how the money was, who the money was given to, and how much. And I would be able to support that amendment. I think these clinics they've seen an uptick for obvious reasons during the most difficult year that Mainers have experienced. Lots of folks have lost their coverage through their employers. And these clinics play an important role in the communities that they serve. And I would be able to support this, support LD 47 as amended. And with that, I would look for a motion. Senator Claxton.
Thank you. Go ahead and move to approve LD 47 as amended.
Second.
Ms. Withy.
Second, don't you?
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
No.
Representative Lemlin, no. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
No.
Representative Griffin, no. Representative Connor.
No.
Representative Connor, no. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Javner.
No.
Representative Javner, no. Senator Moore.
No.
Senator Moore, no. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 6 yes, 5 no.
Thank you, Carrie. And with that, I will close the work session on LD 47. Thank you very much, Representative Brennan.
Thank you. I appreciate it. And have a good day.
You too. Representative Claxton, you have your hand up.
Thank you for that promotion. Can I cast my vote in support of LD 24 on the record, doing it this way verbally and audibly, and have it count. Thank you.
Thank you, sir.
That's Senator Claxton, yes.
Yes.
Yes. Thank you.
Thank you.
Senator Claxton, are you taking the reins here?
Carry on if you're okay with it. I'm still trying to be two places at once.
Thank you, sir. Okay, moving on to LD 17, resolve to provide rural non-medical transportation services to the elderly and adults with disability receiving home and community-based benefits under the Maine Care program.
Okay, I'm going to share my screen if that's all right.
Please do.
Okay, let's see if I can manage to bring the right one up. Can you see that?
We can.
Excellent. Now I can't, however, oh, there's the moving down thing. All right, so LD 17. So this resolve requires the department to establish a pilot project lasting 18 months that allows individuals that are currently receiving services under Section 19, that's the waiver program for the elderly and adults with disabilities, that would allow those individuals to receive up to $2,000 each in non-medical transportation services that are specified in the individual service plan when the individual has no other means of transport, and that is in addition to the currently permissible medical transportation services. So we're talking about other kinds of transportation to other kinds of services. The department is required to submit a report regarding the cost, effectiveness, and future viability of the pilot project to this committee no later than January 30th, 2023. So you heard during the public hearing that Section 19 members currently can only use the non-emergency transportation system, but CMS guidelines allow for transportation for other purposes when included in service plans. That's what you heard from the advocates. And then the department had said that it would be unlikely to be approved by CMS, and therefore it would have to be funded with state funds, which allows for more flexibility, and that it's possible that you would need an 1115 demonstration waiver for a pilot, and that they wouldn't be able to show budget neutrality when they were filling out that application. And the department is currently completing an independent evaluation of the department's current transportation programs, including some information about the New York model. You also heard some requests to include other populations. You had some testimony that would asked you to consider expanding it to sections 18, 20, 21, and 29. And you also heard some other testimony that it should include parents with children in residential mental health services, PNMI Appendix D, for participation in family plans. So there are a couple of drafting issues here, whether you wish to add rulemaking and CMS waiver language as the department requested. I don't know if you need a clarification that the pilot is funded by general fund, but that is also something you could consider. I did wonder if January 2023 is sufficient time to allow for an 18-month pilot and a report by January 2023. This is not an emergency bill, so that would mean that if it were to be enacted and funded and get off the table, it wouldn't go into effect until 90 days after adjournment, and then it would take time to get the program up and running. And this also does require a report for the evaluation, so I don't know if that's enough time or not. And then just a reminder that you had some requests for changes to the population that would be covered. This bill's currently just section 19. There was a request for information about the New York program, and I certainly understand why you would want that. I think the question was motivated by having some kind of outcomes data, but I don't believe that I tried to get that information. You did get some information from the department that they are looking at that program as part of that contract that they mentioned. Their understanding is that this $2,000 benefit is offered to adults and children with significant behavioral health needs, that it's not the same as Section 19. I did also ask Jess Maurer, because this is really her world, and she found similar information, and I sent you an email about that this morning that it is behavioural health homes and community-based services and destinations related to a goal included in the individual's plan of care. But what I think you were looking for was outcomes data, and we don't have that. I'm sure somebody does, but I don't have it. And then the fiscal impact, OFPR's preliminary fiscal impact statement is a one-time general fund appropriation because they don't believe it would be approved by CMS. So it's a general fund appropriation of $583,920 in fiscal year 21 and 22. And there are three components for this. This is a one-time cost. Technology cost for main care to add a pilot project and track the CAP in a member's plan of care. That is $13,920. There's funding for a contract to perform data analysis and report writing of $60,000. And then the cost of the service itself, which is $510,000. I did ask Luke for a breakdown on that, and he said that that's based currently there are 2,550 members on the Section 19 waiver, and there's an assumption of 10% of those using the full $2,000 allowance, because remember, this is specific to those that have no other means of transport. So it's not all of the people that are currently on the waiver. And I just want to take a minute to talk about the technology costs, because this is the first fiscal note we've had with that, and there's going to be many, many fiscal notes that have the one-time technology costs. And there's always a temptation to say, well, we should just say do that within existing resources. Some of these costs will be OIT, other times they will be a contract. They don't get to do them for free. It's not like adding another bill to my bill load and saying, well, that makes no difference to you. The state will have to pay for it in some way. So you can always say that you can always take those technology costs out, but just know that it's still a cost that will somehow have to be paid for. So that's the first time that we've had that come up. It's going to come up over and over again, but I've made my speech now, so I will not make it again. So that's that.
Thank you, Ms. Broom. I see one question, one hand up from Representative Javner, and followed by Representative Perry.
Thank you very much, Madam Chair. I do have a question for the department concerning their independent evaluation of the current transportation programs. Do we have a timeline on when that will be completed?
Is Ms. Bogart still with us?
I'll promote her right now.
Thank you. Also wanted to let the committee know that the bill's sponsor, Senator Maxman, has joined us. Welcome, Senator Maxman.
Hello.
Hello. Question from Representative Javner.
Yes, and I'm going to try and get that answer for you before you're done with this work session. I don't have a firm timeline at my fingertips, but thanks to the internet, I will hopefully have one soon.
Great, thank you very much.
Representative Perry.
Actually, I had pretty much the same question looking at the whole transportation system, because there are so many issues. I worry about plugging in one thing only in a pilot project to find that there is no ability to keep it going, or that the needs really are significantly generally in a much different area. So I'm really questioning doing a pilot project that does not look like it can be maintained. So I'd rather hear the results of the study that they're doing and looking at where the full transportation system is before we jump into this.
Senator Moore.
I agree with Representative Perry. I get really apprehensive about a pilot project this is something I know that we need to take a look at, and I think that we've asked the department to do that, and that's what they're working on. What happens at the end of the 18-month project or the pilot project, and we no longer have the funding? You've got all these people that have become used to it, and now it's gone. I've seen this happen in other pilot projects, and then we have to try to find funding. I just get really apprehensive about a pilot project. I think we should let the department do what they are doing, the hard work that they're doing, because the entire transportation system needs to be reviewed, in my opinion.
Representative Javner.
Thank you, Madam Chair. I'm really curious about the fiscal note as well. It says, and I don't know, maybe Luke's listening out there, but where they come up with the 10%, they say, if an assumption of 10% using the full 2,000 amount. I mean, what do we do in the scenario of if 20%, 30% end up using it? What happens then to the department? I mean, it just seems logical. I'm really curious the way the 10% comes from, and what happens when it is.
I'll check with Luke, but my guess is that assumption probably came from the department, but I'll check with him while you're talking.
I wonder if Senator Maxman, did you have anything to add to the conversation at this point, with some concerns being raised around Logisticare and their capacity?
I would just add, in my conversations with Logisticare, that they're very excited about this idea, and they want to take it on. And I think that the entire transportation system in Maine is in dire need, but we do need to figure out what's going to work. And it's such an immediate pressing issue that personally, I feel like we have to move forward with programs like this. Thank you, Madam Chair.
Thank you. Representative Craven.
Thank you, Madam Chair. I must say I'm no fan of Logisticare, and if it was up to me, I would actually, invite the cab agencies or whatever to be on a more local level, and for them to be more responsible. But if we are to look at the social determinants of health, this is an important area to go. If you can't get to the supermarket and you can't buy your food, you're not going to be very healthy. And this is the nature of pilot projects. We win or we lose, but we certainly learn things from having a pilot project. And I'm very much in favor of this because even though I don't even live in a rural area, I think that people living in rural areas deserve to have services where they can be healthy and where they can live their lives safely. Thank you, Madam Chair.
Thank you, Representative. Ms. Bogart.
Thank you. I do have an update on both questions. The last deliverable for the transportation evaluation will be coming to the department in early March, and then we'll need to review those and weigh in with our recommendations. And so sometime late spring, early summer, I believe we'd have a sense of the transportation evaluation. And then for the 10%, that was an assumption essentially built in, as this is a pilot program to sort of test this model. And so it would be offered to 10% of the waiver program, I assume on some kind of lottery system.
Mm-hmm. Right. So in other words, the number of individuals on Section 19 wouldn't be increasing on demand.
Certainly, yes. And there are about 2,550 people on Section 19 at this time. So it would be 255 that would be offered this month.
And 255 people statewide, not, yeah. Representative Zager.
Thank you, Madam Chair. This conversation is it strikes me as the same sort of conversation that comes with any sort of intervention, whether it be a drug or a medical device or a social program. We don't know whether this will work. And so it would be a disservice to the people if this works. And I happen to think that addressing social determinants of health, like transportation issues, have tremendous potential for improving outcomes for health and lowering costs. But we don't have the evidence yet. It's the same thing as if, before a drug were approved that ultimately saves people's lives or improves the quality of life. At a certain point, that was not known. And people had to take through a structured process of consenting people and enrolling people in a preferably a randomized controlled trial. Then we arrive at the information that can be used to help people. So I'm wondering if Senator Maxman or might be amenable to structuring this in a way that would maybe with the University of Maine system or making this a study, which might allay the concerns that I'm hearing from some members of this committee that we could be at some point taking something away that people get used to. When you have a study, that's the understanding at the beginning, that we don't, as society, don't know if this is a good use of our resources or not. We think it might be, and so we think it's worth trying. That actually is the way that we have, ever since the Renaissance, have advanced our knowledge. So I think it might work in this case.
Thank you, Representative. Senator Maxman, did you want to comment on?
Sure. Thank you, Madam Chair. I am definitely open to the idea of this bill being a study. I mean, the bill does include language that the department is required to submit a report regarding the cost effectiveness and future viability of the pilot project to this committee. And so I don't know if that's what you had in mind or if you were thinking of something different.
Well, I think that's I understand that, and I think that's great. But at the outset, I heard a concern of taking something away from people. So if we enroll people, it's not figuring out, okay, so X number of people showed up or participated in something. What was the effect? We don't know if that's because of what we did or because of some other factor. And so if this were structured from the outset as a and people were consented, that then it would be, I guess there's some parts of the process that would have to occur earlier than just the report of the results. There's like the setup and the methodology of how it's done, which determines the quality of the information that we get and ultimately how useful it is for determining policy. So it's possible that people who have reservations about the proposal as written might have less reservation if it were structured in a way with those earlier steps, such as consenting people, so that they know that this might be taken away if it's found that it doesn't help or that it's not a good use of resources. But we have the potential, just like we have for anything else that has, everything else that's been developed through the scientific method.
Thank you, Representative. Representative Perry.
Thank you. I guess I need to re-ask Molly as she went through the list on the study that the department is doing on transportation itself. Is when did you say there would actually be a report that we, the legislators, may actually be able to see?
March, I think.
So the contractor that we have engaged to do this work will be submitting a final deliverable to the department sometime in March. And then the department will take that information and consider it in the context of the work that we're doing and have, I think, final recommendations for what we propose to change based on the results of that contract I would say late spring, early summer. I hesitate to put strict times on things during this, during COVID, but I don't believe that there's a requirement of a formalized report to the legislature, but I'm sure that Director Probert would happily come and talk to the committee about the recommendations that we received and the ones that we would be acting on once those are ready.
I guess my question is, because that's what I thought I heard, I just wanted to make sure, is that, is there a thing that we could do to create a resolve to have the department look at that as they look at the transportation system, as they're doing the study, so that we're not plucking something into the middle of a system that may not be working well, and looking at that as, is this something that they can add on and do? So there's two things that I think we could do. We could do a resolve asking the department to do that, to look at that as they go through this. The other thing might be, and I don't know how the department, how the other legislators want to do that, would be to table this, and with the possibility of carrying it over for next year. That's just a thought.
Thank you, Representative Perry. Representative Javner.
Thank you, Madam Chair. This is a very good conversation. I appreciate this greatly. I appreciate the information that Molly has brought forward. I agree with Representative Zager. I think that, and I am trusting and believing that the department, through the review of their transportation system, is going to take that into consideration of the scientific data, the process of it, and so that the resources that are in the department already with their transportation, that it is going to obviously come out in a very positive manner. I agree with Representative Perry. Perhaps the best next step would be to table this until we have that information from the department. Timeline, if you look at it, this wouldn't go into effect until June, and then 90 days after June even. And so this isn't even going to get up and running until the end of the year, perhaps even. And so I think I am certainly at the position where we want to allow the department to do their work and to do their job, knowing that we have that they have our full cooperation and leeway to say, we are trusting that they're going to, do this process due diligence. And so I would agree with Representative Perry that perhaps, we could table this for a later date and look at the information from the evaluation of the transportation system. So that's my 2 cents.
Thank you, Representative. Senator Baldacci.
Thank you, Madam Chair. I just want to indicate that I would vote not to table this. I think this is an important issue. Having been serving on the City Council in Bangor and dealing with, because Bangor is a hub for transportation to provide services, not just for Bangor, but for the entire Bangor region, which some of it is very rural and underserved, and there are other agencies that try to help out. I think transportation is like a monumental issue for people trying to get out of poverty or trying to find a job. So, and having them do a study, they'll get information from this pilot project that will probably be more valuable than doing a study. And I understand people's concerns and reservations, but I think it's the best way to get information about how best to design a program, maybe to have a pilot project to see how it works in reality. Because I don't care how much talking somebody does, it doesn't necessarily gonna help us define a program better than the actual operation of it. So those are my comments, and I appreciate your time.
Thank you, Senator. Representative Stover.
Thank you, Madam Chair. I just wanted to ask Senator Maxman what she thought about waiting for the results of the department study.
Thank you, Representative Stover. I'm okay with tabling it. I mean, my understanding has been that this has already been quite thoroughly studied from a number of different angles, which is and so that was, you know, one of the issues that we struggled this when I introduced this last session. So I have a resistance to just the continual study of the problem, but I think tabling until the department releases its report is fair.
Thank you. And Representative Javner.
Thank you, Madam Chair. I think we all agree. We agree this is an issue. That's why the department is doing their review of the transportation system. So I may be a bit naive, I don't know, but I'm very hopeful that through the department's review that they are going to see that, they're going to be able to make some changes, some real positive changes, and that perhaps we're going to see that we don't need this type of a program, that they're going to be able to handle it internally and hopefully even provide more transportation for more than just 10% that this pilot project would provide for us to be able to study. That's my hope, is that it's going to be even more positive than what we could imagine. So if Senator Maxman is okay with tabling, I would, if there's no other discussion, perhaps we could make a motion.
I have one other.
I second. I just want to indicate that oh, Madam Chair, I'm sorry.
We've got a hand up from Representative Lemelin.
Thank you, Representative Meyer. I agree, we definitely need better transportation. There's no question of that. However, if it's not tabled, I oppose this pilot program. Mainly because it does need more study, and I'm not talking about study for the need. We know the needs out there. I think this thing needs more foundation. I don't think it's ready to be implemented, and that's what I think needs to be studied, exactly how this is going to be implemented and if it can be already taken care of within the programs we already have. So this is where my concern is. It definitely needs a foundation. There's something missing here. And that's the businessman side of me that's telling me this. So that's all I have. Thank you.
Thank you. Representative Stover, and then Representative Stover.
One of the things that we learned at the beginning of this conversation from our analyst is that under Section 19, if it's built into the service plan for the individual, that it can be provided. So in addition to thinking about possibly waiting for the study, I think in my mind, if providers of Section 19 services were sent even a postcard reminder that they could provide these transportation services if they indeed put it into the service plan, which is really easy to do because you have a number of areas within that service plan that you want to strengthen around independence and self-sufficiency. So if you built it into your service plan, then you would have a mechanism in the interim to do some of this, which essentially could almost be like a pilot. But I think tying it to that service plan might be a temporary way to address the service need. Thank you.
Thank you. So we do have a motion and a second to table this. And I see our analyst, Ms. Broom's got her hand up.
I just want to clarify the issue with the service plans. So there are a number of sections of main care that have that same kind of language that about things in your service plan and being able to get transportation to them, and that it is in the CMS guidelines. But my understanding, and Molly can leap in when I go awry here, but my understanding is that there isn't a way to bill for those transportation services unless they're on the medical transportation system. So there's this disconnect between, it's not that they're not in the service plans, it's just that there's no good way to pay for it, which I think is why they're looking for a pilot project and a way to get, you know, those transportations for those other types of services that, as you say, you know, are about getting to the grocery store and, you know, contact with other people and all those other things that are beneficial for people. And it's not just in section 19, it's in 18 and 20 and 21 and 29, that same kind of language. And I remember Jess Maurer sending me the CMS guidelines 2 or 3 years ago, but there's this disconnect in terms of how to actually pay for it. And Molly will tell me if I went awry there, but that's my understanding, right, Molly? There's no other way for you to bill for anything that's not on that waiver for the transportation.
Molly's shaking her head yes. Thank you, Molly. Senator Baldacci.
Thank you, Madam Chair. So essentially, Ms. Broom, does that mean that even though it's in multiple pieces of legislation or service plans, that basically that service plan that talks about, that part that talks about transportation is really a non-entity because there's no funding for it, correct?
There's no way to bill for it.
There's no way to bill for it. So there's no funding mechanism where they can bill for it.
That's my understanding.
Okay.
And I'd like Molly to nod again so that I can make sure I haven't gone off track here. Yeah, there she goes.
Yeah, and you know, I would add at the committee's pleasure that there are some services that in our contracts with those services, they include transportation, but not non-medical, not transportation to things that are not in the service plan, I should say, sort of those additional life activities.
So that goes back to my original point and why, even though I may be the only person to vote against tabling, is that the only way we're going to get any demonstrable evidence or education or learning about how to do this is by doing a pilot project. So I don't like to be the skunk at a tea party, but I'm going to have to vote against tabling. Thank you.
Seeing no, Representative Perry.
Sorry, I'm back again. I think my biggest concern is because this has to be funded by general fund, and because we are looking at the total transportation system, and we've got a lot more people who need this kind of help than just section 19. And we do talk about the determinants of health, and we know this could be important, but I want the system to be looked at to see if we can do something like this and maintain it. If we can't do something like this and maintain it, and then bring it up again and again and again, and end up not being able to maintain it, then I think we've done a disservice. I want to know where we stand right now. Tabling just says we haven't made a decision, we're looking for more information, and I want to be as positive about this as it absolutely can be.
Representative Craven.
Thank you, Madam Chair. So we're kind of talking oranges and apples here. You know, the department is looking at, you know, medical care transportation, and that is all that CMS is offering at the moment. So it would have to be an entire, you know, process of going through CMS and that sort of thing to change the rules. So it doesn't, in my mind, it doesn't matter what kind of report the department is going to issue in April. This is a completely different bill in that it would be paid for through the you know, general fund and offered for different purposes. I mean, we have issues here in Lewiston where moms with, this wouldn't help them, but this is an example of how dysfunctional the medical care transportation is. So we have a mom that has to take her child to the doctor, but she has 2 or 3 kids. And so she has to walk to the doctor because she can't put the other 2 or 3 kids into the car with Logisticare or whoever else is providing the transportation. So she's traipsing along in the snow and in the ice, taking her kid to the doctor and just having the other kids follow along with her. Just because that, you know, it just doesn't make a lot of sense. And in my mind, this is completely different, and no matter what the outcomes are, which I'm expecting and hoping that they're going to be positive outcomes in April, this will continue to be a different issue with a different population and for different uses.
Thank you, Representative. Representative Perry, your hand is still up. Okay, thank you. So we do have a motion and a second to table LD 17. Carrie?
I'll start the vote. Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
No.
Senator Baldacci, no. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
I'll be a rebel like Senator Baldacci and say no.
Representative Craven, no. Representative Madigan. Representative Madigan is absent. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 2 no, 1 absent.
Thank you, Ms. Withy. Closing the work session on LD 17. And thank you very much, Senator Maxman. Do we need a couple of minutes break, or is everyone ready to plunge forward on LD 166?
I think we're ready. I'm ready to go forward.
You're ready to go forward? And so we will. Opening the work session on LD 166, an act to allow participants in the Qualified Medicare Beneficiary Program to qualify for main care transportation services.
Okay, so I'm going to share my screen again. See if I can bring up the right one. Can you see 166?
You can.
Excellent. Okay, so Luke already threw me under the bus earlier this morning by saying that the Quimbies were my favorite subject, which because I have to relearn them every year. Okay, so this bill extends the non-emergency transportation services that are currently available to main care members to qualified Medicare beneficiaries, the Quimbies. The department is required to submit to CMS any waivers or state plan amendments that are necessary for approval to provide these services. And if approval is denied, the department is required to reimburse main care providers of non-emergency transportation services with general funds. So only individuals who are fully dual eligible, in other words, they're fully eligible for main care, qualify for the non-emergency transportation services. The department said that CMS won't approve this, so it would be all general fund cost. Right now, the Quimby's, and I'm just going to go a little further down to show you this chart. This is perhaps not the ideal source, but it was the best one I could come up with. It was all on one page. So you can see there what the Quimby's pay all Medicare premiums, co-insurances and deductibles, and lowers generic drug copay. So this is the part A and B. So that's what the Quimby's get in terms of Medicaid. You also heard from the department that waivers, once again, require cost neutrality or savings, and they wouldn't be able to demonstrate this. And that the department also lacks ability to verify trips as Medicare covered services without access to Medicare claims data. So, this is about Quimby. So these are people who are on Medicare, and that's why, there's that issue there. So I did attach that chart for Quimby, Slimbies and QIs, just because I like to say Quimby, Slimbies and QIs because it sounds cool. Just so you knew what we were talking about, but this is specifically a Quimby. The OFPR preliminary fiscal impact statement is 4.7 million in general fund in each fiscal year for non-emergency transportation services. That includes a one-time funding for required technology costs. And I'm not going to give that little speech because I did it already. So, but you can see here that most of this is about the cost. This is an ongoing cost because Quimby's don't currently qualify for non-emergency transportation. It would be a general fund cost.
Thank you, Anna. Questions, comments from the committee?
Carrie, you had your hand up earlier. Was there something that you needed the representative to check?
Thank you, Senator Moore. I was just wanted to notify the committee that I was attempting to contact Senator Pulio in case he wanted to be here for the discussion.
Thank you. So it's my understanding, or if my recall, that the testimony from the department was such that we at the state level have no access to these Medicare covered individuals.
It's that we have no access to the claims data if they were taking a ride for a Medicare.
Right. So no ability.
Yeah.
Okay. No ability to track this. Ms. Bogart has turned her video on and is shaking her head yes. Okay. So while certainly the need is recognized in this population as well, for access to transportation in those areas where it may be difficult to come by, it doesn't seem as though this is even possible. Representative Craven, then Senator Moore.
Thank you, Madam Chair. Yeah, I just feel like since that we have no jurisdiction at all over Medicare, that I would move on not to pass.
I will second that.
Senator Moore.
And probably with that motion, I don't even need to say further, but I did want to point out that the sponsor did comment in his testimony that he realizes that it's a large fiscal note, and with no having to come totally out of the general fund and not federal resources, while it is something that we probably really do need it, but financially I don't think we're there yet. And Senator Pouliot agreed, I think, in after looking at the fiscal note. I just wanted to point that out.
Thank you. Thank you. So we have a motion and a second on LD 166 ought not to pass. Carrie?
I'll start the vote. Representative Zager. Representative Zager is absent. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan, Representative Madigan is absent. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 10 yes, 2 absent.
Thank you, Ms. Wibby. So, Anna, did you have something you wanted to add? Okay, so closing the work session on LD 166 and opening the work session on LD 74, resolve to ensure appropriate personal needs allowances for persons residing in long-term care facilities. Turn it over to Ms. Broom.
Okay. So, personal needs allowance. So this resolve directs the department to amend its main care rules to provide for increases in the personal needs allowance of residents in nursing facilities from $40 to $70 a month, in residential care facilities from $70 to $100 a month. So the sponsor testified that he would be okay with changing the title of the bill to nursing facilities. I think he meant the substance. He had this bill in the 129th as well, and it was originally drafted in the same way as this bill. And that bill was amended to remove the residential care facility piece altogether, and left the personal needs allowance for nursing facilities and amended it to $50 instead of $70. The estimated fiscal note of that amendment was $194,000 in general fund, which draws down the FMAP. And the only reason I actually, well, the two reasons to bring that to your attention: one, because the sponsor did talk about nursing facilities, and secondly, just because we don't have a fiscal note yet, and that would give you an indication. So you did hear that the personal needs allowance had been last increased in 1985, and that Maine's is the lowest in New England. There was a discussion of whether a COLA should be included in this, and also there were questions about who is included in residential care and whether it would include the group homes and the ID populations. So I asked the department about that, and they said that the residential care and the personal needs allowance refers to residents of Appendix C and F. In other words, that is the elderly. That's what we usually think of as assisted living, and doesn't include all the PNMI group arrangements. So it doesn't include the ID population. So there are a number of drafting issues. The first one's not an issue. This is just to remind you that you had this conversation about whether what you should include or the COLAs. But there are some other issues as well. So first of all, you might want to specify which particular rule. We usually try to refer to what rule we're changing in the bill draft. I always have a hard time finding this one, so I'm guessing that that's why. But it is Chapter 332, the Making Benefits Manual. This is the eligibility part. So there are a couple of issues here. So the personal needs allowance in the rules for residential care is determined both for the individual and for a couple. And residential care is, the personal needs allowance is $70 for an individual and $120 for a couple. For if you're on SSI, it's $50 and $100. And part of the reason that this is a sort of an issue, so there's two pieces here. One is that the way it's drafted, it says that the personal needs allowance would go from 70 to 100. And secondly, it also states that persons residing in residence, and it's not entirely clear to me when I read that whether that means a person or persons, since it does in the residential care world also includes individuals and couples. So again, I reached out to the department, and the rules in residential care are drafted to include a personal needs allowance of $50 plus a federal disregard of $20. And that federal disregard is applied once per household. So that's why it's 70 and 120. It's not just doubled. It's because it's really 50. The personal needs allowance is actually 50. So if the way that this is written, it could be read to say that the personal needs allowance for some residents would actually be being increased by $50 a month rather than 30. In other words, if it was a person that was on SSI, they would be going from $50 to $100, because the way it's drafted, it says they would go from 70 to 100, but they were never on 70. That if you were on SSI, because it's a means tested benefit, a needs benefit, I should say, they don't get the federal disregard. So it's just not drafted quite correctly. So the department said if the bill was drafted to say $50 to $80, that would result in the $100 total disregard that is intended, and would cover both individuals and couples, because the federal disregard wouldn't change. Just as a sort of FYI, in the nursing facility world, people on VA pensions or certain people in VA nursing facilities have $130 personal needs allowance, which excludes $90 of the VA pension as income plus the $40 personal needs allowance. The bottom line for all of this is you need to think in bullet points rather than drafting. You just need to decide, who do you want to apply it to? Do you want it to apply to nursing facilities? Do you want it to apply to residential care? And how much do you want it to go up by? And then we can figure out the drafting when you decide where you want to go with it. Just as a little bit of background, the requirements for the personal needs allowance are in federal regulations. There's a minimum amount of $30 that has existed since 1987, and it limits what long-term care facilities can require residents to pay for. And similar state regulations govern residential care, and any income from the resident above the personal needs allowance is applied to the cost of care by a long-term care facility. And that cost of care is the amount that the resident contributes to their care in the facility. In other words, increasing the personal needs allowance increases the amount of Medicaid that's required to pay for the resident's care. That's why it triggers a fiscal note. So since we don't have the fiscal note, I'm just giving you the background there, that if you increase the personal needs allowance, it triggers a fiscal note because you need more Medicaid to cover it. But in terms of drafting and where you want to go with it, if you want to go forward with this, it's just a matter of deciding who you want it to apply to and how much you want it to increase by, and you can leave the drafting to us and the department.
Thank you, Anna. I think I've been invited to take over from here. So I'll go first to Senator Baldacci.
Thank you, Mr. Chairman. I would just indicate that I would like to see a COLA. I would hate to see, 1985, I think $50 went a lot further than it does today. So I think that's the first thing. I would say yes to a COLA. I would say yes to nursing facilities and residential care. And I would be fine with the with Ms. Broom's recommended language regarding how to differentiate between those that are at 50 and those are other numbers. So that's where I would come out. Thank you, Mr. Chairman.
Yes, Representative Perry.
Thank you. The question I have is the nursing facilities. What does that mean? Does that mean just nursing homes, or does that mean the kind of PNMIs where people are taken care of in a home, but it's not a nursing home itself?
If you're in a nursing facility, you get the $40 personal needs allowance. If you're in a PNMI, then that's where you get the 50 plus 20 or the 70. So the people who are in a PNMI are covered under it's the same chapter of main care, but a different part. So that's why it's drafted to include these two pieces separately. And you still need the two pieces separately if you want nursing facilities and residential care. But if you're in a nursing facility, you get $40. If you're in a residential care, you get the 50 or the 70, depending on whether you're on SSI or something else.
So essentially, if you leave it to nursing facilities, the only thing that you are doing this for is nursing homes.
That's right.
And my concern is the PNMIs that are assisted living, simply because I'm just going to try to bring this forward. I had a patient who was in a PNMI assisted living, and she actually needed, I guess I'll call them diapers, but she was so large, she did not qualify for anything that Medicaid allowed. But she still needed these things in order for them to take care of her. So she ended up paying for this out of her allowance and ended up with a bill at the pharmacy of $400 until we finally got the Medicaid to okay the size of her. So the debt was phenomenal for what she needed. And to think that she only had $50 or $70 to cover once a month for needs, I think put her in a very, very bad state. So I fully agree with making it somewhat reasonable, because this is more than just shampoo and soap.
Representative Craven?
Thank you, Mr. Chair. So I guess I'm disappointed that the ID community isn't included in this. Most of them are young people who have to use $40 for all of their toiletries and haircuts and clothing, and if they are going to have entertainment, if they can go to the movies, or if they can go out to lunch or something like that. And so I would ask and see if people, if the committee is willing to include the ID community as well as PNMIs and nursing homes. Thank you, Mr. Chair.
Yes, Anna.
I actually have no idea how much of their income they can keep, Representative Craven. They're not included in this at all because they're literally, the personal needs allowance doesn't apply.
They get $40.
Okay, yeah, I wouldn't have a clue because it's not in this section of main care at all. So I didn't research that.
So let's go point by point. How about a COLA? What's the general sense from the committee about adding a cost of living adjustment of some shape? Anybody got a comment on that? Representative Senator Baldacci's recommendation, yes. Representative Javner.
Thank you, Mr. Chair. I agree that there should be a COLA. I'm curious, though, the time frame of all of that, and is it going to be incremental? Is it going to be every year they're going to get a COLA? Every 2 years? What was Senator Baldacci thinking?
Senator Baldacci?
Well, I mean, I was thinking it would be done annually because Social Security checks are COLA adjusted annually. So it would be in sync with their own Social Security checks being COLA adjusted. That's all. Yeah, but it's a good question. I appreciate it very much. You're right. But I would probably want it to be done annually only because their Social Security checks are generally done that way.
Okay. If I may, Chair Claxton.
Please.
And to that effect, I really don't know, but are you thinking then that the COLA would be exactly at the same point as what does the COLA change, or is it across the board the same? Would it be the same cost of living adjustment as they would get for their SSI then annually?
That was a question I was going to ask of Molly. Is it the consumer price index? Is it a cost of living? You know, what does the department use for COLA calculations elsewhere? We don't need to come up with a different number. We could make it the standard, whatever Medicare comes up with, and it changes year to year. Well, let's ask Molly if there is a standard or a benchmark for that.
I'm honestly not sure what our standard is. If, you know,
Okay.
it would certainly be easiest for us if it aligned with whatever that is, whether it's CPI or not, but I'll see if I can find out.
Okay, so that's an unresolved question. I hear a couple people in favor of considering COLA. Anybody else who's, you know, thumbs up or thumbs down for just a sense? You know, okay. So there's at least some interest in there. How about yes, Representative Javner, your hand is still up. You have a question?
I apologize.
No, no, go ahead.
Wanted to be up in perpetuity, I guess, so I can talk all the time.
Annually in perpetuity. Okay. And what about limiting it to nursing facilities only, nursing homes? Is there some sentiment for broadening that? Senator Moore?
I guess that would be a question that I would ask Senator Claxton. Thank you. When we have someone that is in a long-term residential care facility, do they get an allowance? I mean, is there a personal needs allowance similar to what a nursing home is? I'm not familiar, so I don't know.
Well, that's the 50 or 70 that I was talking about. It's
Okay.
the PNMIs.
Okay.
And I want to be careful we're using the right terms here. Nursing facility as opposed to nursing home.
Right.
And long-term care versus assisted living.
Right.
All those terms aren't interchangeable.
And so that was a question. Do assisted living folks have personal care?
Right. So I'm trying to go through the list. Are we clear that nursing facility and / nursing home folks / long-term care, that I think of that as one category? Are we clear that's the group we're trying to increase the allowance for? I see some head nodding and I see some head shaking. Is that a tremor, Representative Perry, or do you have something you wanted to say?
My problem is I still don't understand it. Because are we considering the PNMIs that is really group living for the elderly, where they are taken care of by personal care attendants, their medications are given to them, but there is no nursing in the facility?
Right.
Is that a nursing facility, or is that a PNMI that is for elderly living?
I think of it as a PNMI. Yes, Anna.
So my understanding, and Molly will tell me if I'm wrong, but my understanding when I look at these res care rules for this section, it includes adult family care homes as well as PNMIs. So it does include those other kinds of assisted living. It's just that it doesn't include the PNMIs that are not Cs and Fs.
They're not what?
Cs and Fs, the ones that Representative Craven was talking about for the ID population.
ID population.
Right.
Okay.
So, but it is my understanding, and I think this is correct, that it does include the adult family care homes, which are, you know, the littler ones, not just the PNMIs. But it doesn't include the PNMIs that have the ID population in it. So I didn't mean to confuse the situation. I was just trying to answer the question that Representative Craven had at the public hearing. But it does include adult family care homes.
When you say nursing facilities, that does include the adult family care facility.
There are nursing facilities, and then there's residential care. Residential care includes PNMIs and adult family care homes. They are different rules for those two types. Nursing facilities are all by themselves. They get the $40. And then there are all the other, you know, residential care or assisted living or whatever term you want to use. It's residential care is the term they use in the rules. But those are the ones that get the 50 or 70, depending on whether you get SSI or some other kind of income.
So the interchangeable terms, we have to go back to the beginning, and Anna, you correct me. Nursing facility,
Right.
long-term care, and nursing home are all interchangeable.
Nursing facility is not interchangeable with residential care, and that's what we're
That I
talking
understand. I
about.
didn't mention residential care.
But that's what's in the bill. What's in the bill is nursing facilities and residential care, and what's in the rules is
Right.
nursing facilities and residential care.
Okay.
Like
And
that's how the rules are written.
And I'm avoiding the language in the bill to get some clarity, because I think the language in the bill, because we're struggling with it. And so when we have used the term nursing facility, long-term care, and nursing home, as I understand it, those three terms are interchangeable.
What was the one in the middle? Sorry, long-term care.
Long-term care, nursing home.
I think long-term care is an umbrella term, so I would leave that out. But nursing facility and nursing home are the same thing.
Okay. That was easy. All right. Everything else.
Yeah, it's a matter of deciding who you want to apply it to.
That's what I'm trying to do.
But I can figure out how to write it. You just need to say, this is who I wanted to apply it to. If Representative Craven wants something for the ID population, I don't know how to word that, but if that's what she wants, I can figure out how to word it. It just would be different language.
Yeah, and I'm working down a list, and I think we got nursing home squared away, and we got residential care non-IDD as another category. And then yes, Representative Javner, did you have a comment?
Yes, thank you, Chair Claxton. Last session when we worked this bill, there was an amendment that we had worked out for it, and I'm looking at that amendment, which I agree with definitely. I think that it helps with a lot of the clarification of the definitions, but also too, if we're going to go with a COLA annually, an annual COLA, in this amendment, it raises the personal needs allowance to 50. And I am still on the same page with that. It raises it, but then again, if we put in the piece with the COLA being annually, I think that's a good compromise, if I can put it that way, instead of raising it all the way to the 70. So I would just put that out there so that I do agree with the COLA piece. I think that's really important as we see that, but I'm not ready to jump right to the 70. I think 50 is a good starting point, and then annually I'm working with the COLA. So the amendment here that we worked on last session is very nice.
And I was going to get to the number or how big the increase was after we got the categories sorted out in our own minds. Okay. Anybody else want to articulate an interest, including the ID community, the ID res care? Anybody want to support Representative Craven and her wish to expand that, to include that group? I see hand up from Senator Baldacci. I'm not seeing, sort of seeing him. Senator Baldacci, are you with us?
Yeah, I am. I'm just trying to figure out how to do this. Thank you. Are we right there? Yeah,
There we are.
There we are. I would support Representative Craven's position. I mean, just having, I think any of us who have dealt with many people in nursing homes or long-term care facilities, this is a minimum amount to have some personal dignity and personal care, and it's over a month, and it hasn't been changed in 36 years. So I just think it's really providing a little dignity to people in a very difficult financial and health situation. Thank you.
Thank you. Representative Perry.
Thank you. I'm just sort of thinking this through. I like the idea of adding the IDD or any long-term group home or whatever that has such an allowance that goes with it. And if we do that, the possibility of Representative Javner's thought of maybe raising it to 50 and then having the annual COLA so that will always go with it makes sense as we add groups.
Okay. All right, so I see some interest around that. Representative Javner.
I so miss the horseshoe. I'm sorry.
I mean, I know, me too.
So I totally agree. Of course, with including as many of the population as we can. My hesitation, of course, is going to be that we end up with having such a huge fiscal note that it's not going to make its way off the table even. And I think that the way that we have it right now, and just jumping to 50, adding the COLA even, that just, in my opinion, it creates a better pathway to actually getting funded. And then again, moving forward, maybe with joining other groups, I don't want that fiscal note to be so astronomical that it doesn't ever get off the table.
Representative Craven?
Thank you, Mr. Chair. Thank you for, I do thank people who are supportive of this. I just feel like often our folks with intellectual disabilities are undervalued and devalued and left behind so often. And really, I would love to see them included in this increase. And so I thank you.
Yes, Senator Baldacci.
Okay, in the interest of trying to work something out that will pass, I mean, I think that we need, my opinion is we need to raise the amounts now because they have not been done for 36 years. And if people want to delay like have a provision that says after 5 years from now, cost of living adjustments will begin, or some language like that, I would be amenable to that. But I think it's more important that we do some increase now, and then maybe if people want to delay cost of living increases 4 or 5 years out, which means it will cause no fiscal impact on a couple of budgets, then I'd be more amenable to that. My concern about the COLA is not that it has to start right away, but we had a system where these things were embedded in stone and it took a generation just to update them. So I think if we provide an increase now, and if people want to delay the start of a COLA 4 or 5 years out, I am fine with that, but I'm just trying to throw out ideas here that might work.
Okay. So what I've heard so far is that there is an interest in the COLA and there's flexibility about when that kicks in. That could be the next fiscal year or the year after or 5 years from now. I've heard interest in increasing the nursing facility allowance from 40 to 50 instead of what's 70 in the bill. And I've heard in addition to the current res care allowances and assisted living, that there's an interest in expanding that provision to include the IDD community in group homes. Not uniform interest. I'm not saying that, but those are the distinct pieces that I'm hearing. Representative Perry.
I think I just forgot what I was going to ask. I'm sorry.
Thank you. Representative Javner.
I didn't forget. I'm sure you're wishing I would forget, but I haven't. Is the sponsor of the bill available? Because I would really appreciate to hear his perspective for these ideas that we've been kicking around, if possible.
I have a question for Anna. Can we get the fiscal note broken out so that we know what the cost is, A, for nursing home, long-term care, B, for PNMIs that provide services, and C, the IDD community? I think if we're going to send this to the appropriations table and cross our fingers, I think giving them some ideas of what the impact would be by various categories would be helpful. Is that something we can do, Anna?
Well, we don't have a fiscal note at the moment, so that makes it possible. But they don't usually do fiscal notes until they're drafted, but I could see what is possible. And I'll have to do some research on the ID side anyway, because I know it isn't called that. Margaret Craven knows more than I do already by knowing that it's $40. I actually don't know that.
Yeah.
So we can see what we can find out. I mean, it's always an approximate cost anyway, but
Sure.
but I'll talk to Luke and see what's possible. And if he tells us that you need an amendment in order to do a fiscal note, then we can go down that route. You can always revisit a fiscal note, but I'll see what I can find out in the meantime.
And I think the goal for today is to come out with some clear instructions for you about what the bill should say.
I do think we need some idea of an amount in order for them to figure out
that's what I meant.
semblance
Yeah.
of the cost,
Amount
right?
and category.
Right.
Yeah.
The categories, we can work that out afterwards, I think. But
Okay.
is it, $10 on nursing facilities and $10 on res care, or is it $30 on nursing facilities and $30 on res care?
Okay.
It would be good to have a ballpark.
Okay.
So that I can ask Luke.
Representative Meyer.
Thank you, Mr. Chair. Yes, we need to know how many people we're talking about here if we're going to widen this to the IDD community as well. So I'm not sure we will have any understanding as to what our options are as far as a fiscal note until we know how many people we're dealing with here as we widen this out. I mean, it was my understanding that it was the sponsors, if I recall from last session and this, when it was presented, these were nursing home residents.
Representative Perry.
I remembered. Sorry, but concerns about the COLA. I understand Senator Baldacci's question about doing the raise first and then a COLA 5 years later, which can be ignored. I would rather have this set up as an annual thing to be done annually so that it doesn't get ignored. It is the reason we've gotten into the situations we've gotten into is that we have chosen not to make any changes in numbers. But if we have a process for increase, then that will be much more difficult to ignore and will more likely be maintained through the years.
Yep.
And so I just want to put in a vote or a concern about holding off on COLAs.
I used to be young and cynical too. Thank you. Senator Baldacci.
Thank you. I think we need to make a motion, or I'll make a motion to table this until we can have a lot of stuff answered that people have raised today. I would make a motion to table. It's up to the chairs when they want to reschedule it, but I think there's been several requests for different kinds of information, and I think some refinement and some clarification. I think people, before we can vote on a final bill. So I would move to table, subject to getting that information.
So there's a motion on the floor. Do I have a second?
Okay.
Does anybody want to?
I'll second it.
Senator Moore is seconding it. Okay. So Carrie, can you call the roll for a tabling motion for reconsideration at some future date with multiple questions answered? And then we'll go to making sure we have a full list of the questions to be answered before we leave the topic. So Carrie?
I'll start the vote. Representative Zager. Representative Zager is absent. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
You're muted. Can you say yes on mic, please, Representative Perry?
I
Or-
thought I did. Usually
I was reading your lips.
trouble not muting. Yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes.
Okay, so we need to give Anna some direction in terms of trying to wrap up the questions that were unanswered. Oh, Representative Connor.
Thank you, Mr. Chair. Very quickly, I apologize. I have to go to another committee. I was asking the chairs to excuse me, please.
Oh, certainly. You don't even have to ask, just go. Senator Baldacci.
And I have to attend a meeting regarding Bangor International Airport with with the Bangor legislative delegation. So I will try to jump back into this around 3:30. But
I'm hoping we're done. I'm hoping we're done by then.
Okay. Well, I just want to let you know.
Okay.
Excuse
Thank
me.
you.
Yep.
So Anna, how about and I'm gonna put together what I heard as some interest and not reflecting the committee's interest, just to give you some sort of direction. And what I heard was an interest in a COLA, to be determined which one. And I heard interest in it being applied annually, and we could pick a January whatever start date, like 22, or we could do it this year, after passage, whatever. So I heard that. I also heard interest in the nursing facility expansion of the current benefit from $40 to $50. And I heard interest in increasing the res care assisted living dollars from 50 to 70. That one I'm less sure about. We'll come back to that if we have to. And I heard interest in expanding to include the IDD residential care facilities and people who reside there. If I'm not close, please let me know, because that's what Anna's going to work on until we give her some other direction. Representative Craven.
Yeah, I'm just getting an estimate of what the fiscal note might look like.
Yes, that would come with it, and my request to try and do it in parts if we could. Representative Perry, you look like there's a question on your face.
No, just looking things up.
Okay, all right. So is that close enough to what we wanted to be talking about for now? I see some head nodding. Okay. Is that enough direction for you, Anna?
I shall see what I can do. Or rather,
Okay.
what Luke can do.
Yeah. Work on your delegation skills. There you go. All right. Okay, so this is tabled until some future work session, depending upon how long it takes to get information back from Luke and a redraft from Anna. And all of those numbers that we just mentioned are all up for negotiation and flexible, but we needed to draw some lines that were clear in the conversation. So that's where it ends with that one. Okay. Anything else on the agenda that I should know about? So Representative Lemelin voted with a head shake. I'll take that as a motion to adjourn. Representative Lemelin, do I have a second?
Yes, sir, that's correct.
Second.
All right. Okay, there's a motion to adjourn with a second. All those in favor?
Aye.
Thank you all. Have a good day.
Are we
I'm
going
just-
to meet as the chair and leads?